The answer is
So
yes.
where would you see? Where would you know? That's for feedback.
Going through and you know. She was I'm just saying. I like your point about that.
You went over the overall plan.
Yeah, so show her target for here, you know.
Okay. Need to call the meeting of the North Lincoln County Hospital District to order. We have some public visitors. Notice Linda Hedges here from our foundation and the auxiliary. She has a dual role. Appreciate you being here, Linda. And would you guys like to introduce? Oh, we're going to see you later.
Yeah.
You're John, right?
Yes, that's correct.
And we're going to see her too. I forgot your name.
I'm Allie Milton.
That's right, Allie. Thank you, Allie.
You bet. Thank you.
I'm just old. Forget things. Okay. Minutes of April 29th. Entertain a motion.
I make a motion that we approve the minutes from our April 29th meeting.
Second. Second by Clint. Moved by Mindy, seconded by Clint. Any discussion on the minutes? All those in favor?
Aye.
Any opposed? Agenda, adoption of the agenda? Motion?
I make a motion that we adopt the agenda as written.
Second.
Was that Mindy?
Yep.
Moved by Clint, seconded by Mindy. We adopt the agenda as written. Any discussion? All those in favor?
Aye.
Any opposed? So I think turning some time over to, I don't think it's really Cole Helm. Oh. What are we doing first? Compliance?
No.
We're gonna do a little, excuse me, it is Cole. This is Wyoming Health and Clint.
Cole and Clint.
They're gonna train us on what they learned at the spring convention at Wyoming Hospital Association.
I'm gonna punt Clint first.
It was good. We got you guys, we brought these books back, Dan did, and it's a very good read. The first guy presented on it, and so I'm obviously not going to go through all the 40 maxims, but there was some stuff that, you know, just to kind of give you a highlight of what we went over, and good stuff, and stuff that, I mean, that I think we do pretty good at, for sure, already, but some of it just bears quickly bringing up, you know, just generally accordingly, your board bears ultimate responsibility and accountability for the organization. Everything it does should become stewardship of its resources, capacities, and how well it serves your community. Flipping over, both interest and commitment are necessary ingredients for great directorship. You know, some other points, you know, one of the positives that we should embody as individual members, we are inquisitive and somewhat skeptical, not totally accepting. You know, because that gets feeling a little bit uncomfortable when you're sitting here with the CEO and the other admin team, and you know, you feel a little bit out of place when you are somewhat skeptical and unquestioning. But throughout this book, they bring it up quite a bit. It's pretty important. Another one, management's job is to run the organization. The board's work is to ensure it runs well. A board's fundamental and overarching obligation is to make sure the organization benefits its stakeholders. And, in our case, a lot of that is the community. A big part of that is the community. Your board's job is to represent, but it must do so by balancing and aligning the different emergent interests of various stakeholders. What you must not do is serve as a narrowly focused standard bearer and single issue advocate. Maxim 24, play devil's advocate. And that's one thing I appreciate about Marlo. A lot of times seems like everything's cut and dry, but then he'll question stuff. And I think that's very important because that does stop even your thought process and make you relook and re-examine and think about things. You go, yeah, why is he asking that question? So it's good. The one that really stuck out to me, be prepared to vote no. And one of the things on here that it says is, if you do vote no, make sure it's in the notes, but then it even goes so far as to say, prepare a statement that you can then give to Andra that you ask to be addended to the notes explaining your vote on it. Then we went into a conversation on generative discussion. Generative discussion, this is kind of what is a generative discussion? Overall, it says, are we solving for this year or are we planning for next decade? A generative topic discussion is not a decision for the day. It's a multi-month decision to frame out for a decision and presentation to the board. A generative discussion requires three things: structure, an agenda and framing, capability, direction, director or board confidence, and culture, candor and courage. So it was just good. It was good. It's always good to go to these and just get reminded of these things that you should be doing that might feel a little bit awkward. And because that's why Dan gets paid, is to get some pushback and let him think, yeah, why are they asking that question? I may have brought it up before, but it's really easy to get focused on the bright, shiny object when you're in positions like Dan in administration, and sometimes you miss stuff in your periphery, not through ignorance, not through malfeasance or neglect, just because you're focused on the shiny object, and there's some obvious answers in the periphery. And I think that's where, as board members, we can come in and just throw that out as to, hey, what about this thing over here? So that's my report on what we learned.
That's great. I apologize for butting you to start off with, but that's why I did it. It's very important. But a couple other things I wanted to add to it as I was looking through my notes here. A few things, and starting off with the 40 maxims. That was, like I said, like Clint said, that was the first thing we went over, first presenter. One of the things I picked up on, though, that they talked about was mentoring our new board members. So we're in a situation where we have election coming up this year. We have elections coming up, every couple of years, where there is an opportunity for new board members, and he talks about the importance of mentoring the new board members as they're coming on. And I think that's not only, a lot of times admin does a good job of bringing them up to speed, but I think as board members, I think it's something that we can look at trying to help new members get the feel of things. Should we have new members come on? The other thing is board members, they talk about analyzing what's expected of us and kind of do the self-analysis as far as that goes. And getting to know the importance of getting to know our colleagues as far as not only the admin team, but the other board members interacting and getting to know each other so we have a good feel of who we're sitting in the room with at the time. And then again, they touched on and just to recognize the difference between governing and managing, and then respect it, which I think it's a fine line. And they talked about how a lot of times board members have previous experiences, or other business experiences, and so on and so forth. And it's natural for board members to try to get into the management side of things, when in reality we need to try it in the boardroom. We need to try to keep it to governing work. And I think it's a good reminder. I think it's something that obviously is important. And then the other thing I picked up on was, or one of the other things was that we need to recognize or identify and represent the stakeholders. There's a lot of different stakeholders that brought up something that we can dive into further potentially down the road, but talking about whether it be the community, employees, community businesses, the biggest, if we're the biggest employer in the community, just the different aspects, different stakeholders that we represent. And then did talk about the, helpful for board members, of course, to get familiar with Robert's Rules of Order. And I think that's something we can always continue to get better on as well. One of the things I was going to follow up on, and I have not done so yet. They had a book I thought was kind of compelling, but it was If Disney Ran Your Hospital, and that's something that I will follow up on and let you guys know how it is. But it was something that I thought.
The all fun and games, is that what it's?
Well, hey, you never know. I mean, one thing about it, they do a great job marketing, and they do a great job with their brand. So the other thing that I picked up, again, I mentioned governing work at boardroom only. Did talk about not planning votes outside the boardroom, and be careful of factions and cliques, that they can be very dangerous. The other thing that came up was not to make individual requests of CEO and executive team members. And I know this is something we've approached in the past, but they really strongly recommended that we run those requests if we have a request of, say, Scott, for financials or something that we're wanting additional details on. He really encouraged that we run it through the board chair. And I know in the past we've kind of said, hey, contact Dan, but I think it makes a lot of sense personally. It's something I don't want to step on Marlo's toes here, but to have Marlo involved in those requests as we go forward. So something to consider. And then again, I guess the other thing that came up was as board members doing a self-assessment. And just kind of self-assessing where we are at as a board member, the value that we're adding to the organization. Just make sure that we're showing up for functions, fundraisers, recognition dinners, etc. Just reiterates the importance of that to an organization or to a board. And then again, going to the second part of that conference, the generative discussion. Honestly, it was a great presentation. A lot of discussion about actually framing it and how to potentially ask the right questions to, I guess, encourage discussion. One of the couple things I guess really there's a couple things that I took from that one specifically, and it's having us answer, what does core service mean to our organization? And what is our core service? What does that mean? And the importance of defining that, and so that we can all get on the same page that way. As well as and then I was just gonna say, really, I guess, and that last note I had didn't make a lot of sense, so I'm not gonna repeat that one, but just make sure that we're vested in. And like I say, that the discussion is generative is a big part of it, just framing it and making sure that we're asking the right questions in the right way to help encourage the discussion.
Mr. Chair, may I add something?
Please.
First of all, just want to thank both these gentlemen for attending and for the input that they provided me. And the book is fairly, it's pretty good. We tried to buy some more copies of them. $37 each, aren't they? So not cheap. But one of the maxims that I learned that I'm wanting to implement now is I've enjoyed having some one-on-one conversations with board members. The book actually discourages that. And except for the fact that it gets lonely at the top, and there's times where I do need somebody to talk to. And there might be some situations where you might have some type of concern or issue that we just need to address. But I'm putting into practice the recommendation in the book, and Andra we're going to basically change the way that I interact with the board on a really an as-needed basis. So I just wanted you to be aware of that these are, again, it's all about learning, it's all about growing, it's all about trying to do things more effectively. And that's one change that I've implemented from the stream.
And why does it say that? And I disagree with this author.
Well, I think in your particular case as a chair, I'm going to have to meet with you regularly. That's the exception.
Yeah, but the intent of that interaction is to plan an agenda.
Yep.
Or we reached out to him to know what the concerns that he's bringing.
Yep.
So I think it's good advice.
Any other questions?
No, sounds like good training. Thanks,
So
guys.
did we learn anything about other hospitals and hospital districts in the state of Wyoming, how they're doing, what their health is? Any private conversations with any other board members? Anything come up?
It was a little bit too, we were hoping that the activity that we had the day before it got canceled, I think we would have maybe had an opportunity that was pretty short and compact. They had maybe some side conversations about charitable foundations and the like, but I don't know, were you able to glean anything from other board members in that time period?
No, not me.
I guess the one thing I'd say is I think that I think that it's pretty obvious to me when we started getting into legislative update, some of that stuff, that there was, a lot of organizations, a lot of hospital districts, whatever, whether the district or not, across the state, they're encountering a lot of similar issues and have a lot riding on what happens with legislation. So I think from that standpoint, I think that everybody is for the pinch. Had a chance to visit with the hospital group on the Sheridan quite a bit, and they're feeling a lot of the same pressure. They actually, I was trying to think, now they approved their Medicare and their uninsured and all that together, but I think they were right around 70%. And they're actually
They moved to a critical
is it
access
official
hospital.
now? They did move it. Okay, so yeah, they just moved to a critical access hospital because of that. But encountering a lot of the same stuff that we're talking about. So, again, that's some of the stuff I believe it just from that.
Thanks. Anything else? Sadie, I think you're going to give us some instruction. Yeah. Got no rings. No, you better.
Let me share, Andrew.
That kind of is on the screen.
Okay, so this is our annual compliance training that we do for our ACO. It's provided from our ACO, so these are their slides. I'll just kind of go over them. Topics that we'll discuss is what an ACO is, why compliance with the ACO matters, things to know about the ACO, and what to do when there's suspected non-compliance. So an ACO stands for Accountable Care Organization. It's a group of doctors, hospitals, other healthcare providers who voluntarily come together to coordinate care for Medicare patients. Everyone's considered a ACO provider when you provide healthcare services that are billed under the TIN of an ACO participant. So that would be all of our providers. It's not a closed network. It's not a type of health insurance or a Medicare Advantage plan. The providers that participate in the ACO are supposed to promote or uphold the beneficiary rights, such as the freedom to see doctors of their choice outside of the ACO network. So some of the benefits, why do we participate in an ACO? It gives us an opportunity for shared savings that result from providing high quality coordinated care to Medicare patients. CMS scoring benefits that can result in a higher Medicare payment adjustment in subsequent years. It gives us access to unique services and resources, providing actionable data to help providers identify the services patients need most. And we don't participate in the last one. It's an ACO waiver that we could do, but we're not participating in that.
So, say, where do we see those savings? Where does that show up? Is that in
We have not,
interim rate adjustments? I mean,
no, so we are part of a conglomerate of a bunch of other smaller hospitals throughout the country. And because you have difficulty managing the risk of a population without large numbers. That's the main reason. Otherwise, critical access hospitals would not participate in this program. And so we have not seen any savings from this conglomerate of smaller hospitals that we're part of yet. It is mostly us just implementing the necessary changes just in case CMS makes a dramatic change in reimbursement that is more value-based versus cost-based. And we're helping our physicians understand what that world looks like right now, but there isn't a financial incentive to do this for us right now. It's more of just participating to give us experience.
is there any tangible benefit to the patients to
Yes.
do it, or is it more of a structural benefit?
It's way more proactive medicine. So we have care teams that proactively reach out to the patients to get wellness checks, to control certain comorbidities. It is an initiative by the federal government to incentivize us to do that, even though, now the one incentive I will say is that physician fee schedules are enhanced, not reduced if you're participating in an ACO. That is the main reason why we're doing it right now, so that we don't go backwards with physician reimbursement from Medicare.
So compliance, why it matters. So if we run into non-compliance, some of the risks that we can have is obviously a termination of our ACO contract with CMS, the loss of the shared savings, there could be financial penalties, again, the termination of the ACO, there could be corrective action plans, and then personal liability if it's severe non-compliance. Okay, so what you need to know about the ACO. So Medicare beneficiaries retain the right to choose their healthcare provider. So if they see a primary provider here, they have the right to be referred to anywhere they want outside of the ACO or in the ACO. So referring within the ACO may be helpful for managing patient care, but ACO providers may always refer outside the ACO when the patient expresses a preference for a different provider, or the referral is not in the beneficiary's best medical interest. Beneficiary inducements are prohibited, so we cannot provide gifts or free services to Medicare patients. We can't offer patients cash or cash equivalent or routine waivers or cost sharings. Limited exceptions exist around certain very low cost items or item services necessary for medical care when part of a valid program. So we, like I said before, we don't do the ACO waiver program. We're just not stepped into that field. So marketing and promoting, we can market and promote our participation in the ACO. Sometimes we will have to submit that to CMS to get their approval before we can share that marketing information. And then you may have seen around the hospital some of our beneficiary notices signed. We also give them to patients on their first Medicare visit. And then we also do, after 180 days, we follow up with them to make sure, see if they have any questions. And then if you suspect that there's any non-compliance, there's a couple different ways you can contact me as the compliance officer. Welvana, who is our ACO, they have a compliance team email, and they also have a anonymous reporting line. So those are kind of the three ways if there's suspected non-compliance. And that's all I have. Any questions I can answer?
So I guess Dan probably already answered my questions though. So we don't have any savings in dollars. What we do have is about a reimbursement for Medicare on physicians, but not on the hospital. Right? Okay. And so how is our program doing? I guess, do we have concerns about compliance?
No, there's no concerns with compliance. I will say on the quality side, and Jeremy can kind of speak this too, there's lots of metrics that we monitor. We track the number of annual wellness visits that we do. And we're always trying to increase those. So that's the no cost to the patient Medicare visit, where we go over lots of different metrics to make sure that they're getting the preventative care that they need. We look at colonoscopy screenings, mammograms, hypertension, diabetes. Those are some of the metrics that we're hitting, and we share those in the quality meeting.
So all of our physicians are being proactive about making sure our patients are doing what they're supposed to be doing.
Yeah, it's a challenge, right? We have run into some issues of just trying to educate the public of what annual wellness visits are, and that we're not trying to scam them. Like, this is to help them be proactive in their care. But yeah, for the most part, we're doing pretty good.
It's mostly driven by primary care, Marlo. Specialists are not, there hasn't been a push. It really starts with primary care, and then it goes from there. But until physicians really feel the pinch financially, they usually don't engage that much. Except for the fact that they, feel like it's good medicine.
Okay, so I guess do the benefits outweigh the negatives of being? We've been involved in this, what, Mike, 5 years? Or Sadie, you may know too.
2018.
18, more than 5 years. Okay, almost 8. Do we find it beneficial now that we've been involved? I remember when we started this, we were thinking this might help, this might not.
I would say,
Do we find it that it's more beneficial than it is non-beneficial?
I don't have any flashy statistic to say, oh, this is working so well. It's just a different environment here in Wyoming. There's not, I don't know of any other ACOs in the state. Am I wrong on that, Mike?
We're the only ones.
Yeah, that's what I remember.
And so the rest of the country is just many, many years ahead of us in the approach to medicine, because the financial consequences are very real in those markets. We haven't felt it. And I think the benefits are, one, we ensure that the fee schedules of the doctors don't go backwards. 2, we give the physicians experience in this value-based world. And just in case something does happen with the federal government and the reimbursement for our market. And number three, ultimately, there has to be a belief that this really is good for the patients.
And that was my next question. I'm not so concerned about the financial side, although that's important. Do we find it beneficial for our patients?
Yeah, I would say so. I mean, one of the metrics that we look at is patients who went to the ER who could have been prevented from going to the ER. So we're monitoring that number, and it's going down. It's going
How
in
we
the
connect
right
them to a
direction.
primary care physician and have them go through a primary care physician rather than spending money.
Yeah.
In the ER.
I mean, ultimately, Medicare wants to somehow control the cost that it's having to take on with the rising
Sure.
population of Medicare, the number of Medicare beneficiaries, and so it's breaking their budget. And so what they're trying to do is say, hey, how do we get ahead of this so that we don't end up paying the high dollars in medicine? Can we spend those dollars in preventative measures?
Sure.
They can take a lump sum and pay the ACO to manage a certain number in the population.
That's correct.
Yeah,
Yep.
not here, but in theory. And it would be, you need a lot of years to like get to where we're at in our program. If they all of a sudden implemented it, it would be disastrous.
And Marlo, some of the things that we've been working on that have came from the ACO is diabetes. So Mark Larson, one of our APs, is working on a protocol where our patients who have diabetes over a certain amount are automatically have an order placed to get their A1C drawn every 3 months, so that our patients have easier access to see where they are and get the help that they need. And then Dr. Kirk has been working on a blood pressure, making sure that we're checking blood pressure. If it's high, we recheck it, and then getting them to their primary care provider if the high blood pressure is seen in specialty clinic. So I think from a care standpoint, it's the right thing to do.
Yeah, and that order is standing, but there was a glitch in that, and I think it was Mr. Larson that was saying that was a barrier to getting these people. They're not getting A1Cs timely because them thinking they have to reach out to their physician to ask for, not knowing when they're going to show up. But because this conversation's happening, we figure out policy that allows it to be a standing order. They're more regular to get in there. Then we have more metrics to see, do we need more education? Are we following up more? It's good.
And that's just further evidence that you don't, as an organization, you just don't wake up one day and say, hey, we're going to do value-based care. I mean, it takes years to implement processes, standardized protocols, make sure people are on the same page and agree about how to go about things. And so, yes, we're the only ACO in Wyoming, but boy, do we have way more experience than everybody else if the world were to turn on us. We're very, very far ahead of most in the state.
Yeah, it seems highly unlikely that they would reverse course on this value-based.
Right. And when they decide to implement it, it's not like they're going to give you a really sweet grace period.
No.
So.
They've said, hey, you could have joined an ACO for the last decade.
Yeah, but to Marlo's point, the better we get at our systems, it does help our population age more gracefully. We don't just ignore the blood pressure thing, we can follow up. And I don't know if we have designated nurses to making some of those follow-up calls or not. That, I feel like we do, yeah.
Yeah, we have population health nurses in our clinic. That's very nice.
Those calls.
Yeah, those ones.
Anyway, okay. Thanks for the report and the education, Sadie. Chief of Staff report is written. Anybody have any questions? Don't see our Chief of Staff with us today. Buddy. Moving on then, we have financial results and statements. So we have a consent agenda. Anybody want to pull anything out of the consent agenda? Anybody have any questions? We're going to be talking in under finance and instruction about our budget, which is probably one of our biggest discussions today. Anybody want to any Thing from Scott or Tanya about our financials through April or statistics. Scott, is there anything that we need to point out that was unusual or something we may not have picked up?
Yeah, I'll touch on a couple of things, Mr. Chair. We had on the balance sheet, a couple of things you could note. Our cash did improve slightly. AR is fairly flat, but one thing you might note on the asset side of the current liabilities, there's $1,000,004 or $1,397 receivable. That's from CMS. We have yet to receive the $1,004,000. We're expecting that by June 15th for the 2025 cost report amendment. On the liability side of the balance sheet, we did, you can see some movement in AP going up that provided a source of cash for us as the payments flow and timing of such. We did add on the third line down in the current liabilities an additional $200,000 to potential settlement for CMS related to 2026. Just based on our volumes that are going up and our costs, the way they fluctuate with the volumes of Medicare patients. So we felt like we needed to add a little bit more to that liability, that estimate. We'll probably add a little bit more this month unless something happens, but we're running pretty hot volume-wise and Medicare patient-wise. So we could end up at the end of the year with the cost support owing amount of money. Another way to look at it is the free interest loan. So they haven't adjusted our rates for several months now. So that's the status on the balance sheet. We're at 52 days, 52.2 days in AR. So we have some more room to go there, but a year ago, as you look at it, last June it was 96.6. So that's a lot different. On the so any other questions on the balance sheet I could answer?
That's a little on it.
Oh, Tanya reminds me, tomorrow we're meeting with Ide Bailey to finalize our cost model training for the cost report. So probably apply that in May, which is next week, or the end of May. Okay, so on the income statement, we had a very strong top line, gross charges. And we won't go through all the deductions from those, but we ended up with total revenue for the month of $10,150,000. Very good month compared to the last several. 10 months ended, we were at $96.7 million for net revenue compared to 93.3 last year. We have, to compare to last year, you look at the recovery rates are lower, and that's because of our mix, as we all know. On the expense side of the house, because our revenues were a little bit higher than they have been, our salaries, wages, and benefits percentages is down, yet for the 10 months ended, we're still at 66.4%. One little bit unusual item that we found out about in April was in the supplies line. It's about $300,000 higher than we expected it to be. That relates to a 340B expense that had to be recognized when we found out the pricing on some drugs was incorrect. It wasn't necessarily a find fault thing, but we were made aware that a program we thought was available to us wasn't. Those drugs are all been sold for about $800,000 worth of gross fees, but we never recognized the proper amount of cost. So that $1,326,000 is high, about $325,000. So we ended the month with just about break even, a $295,000 loss compared to last year's break even. Year to date, we're at We have a earnings before depreciation of 4.8 or 4.486 million, a loss of 3.3. So that's kind of the highlights. So it was a good month in some good ways.
One of the, Mr. Chair, one of the, I think the questions that came up in the finance committee was, all right, why such a, on the bottom line, you know, that 3 million number loss? And when you look at explaining the variance to plan, if you look at our plan, all of our expenses are, maybe except for one line item, are below plan. So we're managing expenses extraordinarily well according to the plan. The issue is the Medicare mix. And if we planned on a Medicare mix similar to last year, but if we had the same Medicare mix as last year, we would be at or above plan. And that's really the main driver of the variance on the bottom line is the amount of reimbursement.
Okay. So why did you bring that up? This is as good as any for my comment. Because I've been thinking about this Medicare mix. I think we're blaming Medicare way too much. I think we ought to call it a decrease in commercial or commercial. I don't know. I think we ought to be focusing.
Commercial attrition.
Attrition.
Yeah.
And I'm not disappointed. I mean, Medicare mix is fine. It sounds really good. It rolls off my tongue really well. But I wonder if that causes us to focus on something we know is there. It's not just caused by the Medicare, but it's also caused if we're having a decrease in commercial. I'm just wondering about, and my observation is, which do we want to focus on? We focus on that it's Medicare that's causing us problems, or that we really need to get more commercial in? Does that make, it's just, I remember reading through everything and writing down a note that says,
No, I
it
think,
seems like we ought to focus on the other on the side where we need to grow.
and again, I make that generalization. Maybe you're asking me to be more specific. So,
No, I'm not being specific. I'm just saying let's,
We can't solve that people are getting older and that they'll come here regardless, they don't care what the price is. We can control people evacuating our services.
I don't want to evacuate, but yeah,
They are.
not always coming here. Attrition.
so it depends on the service line.
Yeah.
I mean, it really,
And we don't disagree.
Yeah, we don't disagree.
it really does. I mean, you're gonna have some commercial leaving and what, you know, you ask the question, okay, well, how do you get more commercial people here? Well, in people's minds, why don't we just lower the charges and appease the public concern, and then they'll come back. We've already had that discussion, right? So the issue that all commercial people are facing is I am feeling the pinch of how much money I have to pay for my care. And if that pinch is big enough and they don't want to travel, or if the pinch is big and they feel, no, I don't want to shop around, they'll come here. If they're feeling the pinch and they're willing to travel, they're going to find some alternative.
There are certainly alternatives.
Right? So I think the solution that we're trying to provide the community is, hey, listen, if you have an out-of-pocket expense that is significant, we're going to provide a significant discount if you pay in full, but we got to get paid. And that, so we're not ignoring
And I'm not saying we're ignoring.
we're not ignoring, because we just had a discussion on the.
My feeling is we're emphasizing that it's a Medicare problem, and it certainly is part of the problem.
So it's not meant to, it's maybe it's an oversimplification, but when you look at, well, you know, just in talking about the business, when you look at our Medicare mix, whether it's decrease in commercial or actual increase in Medicare, it is a 5 to 6% delta from previous years. So however you want us to couch it, we can couch it that way.
I'm just saying, I think we ought to look at the other side of it more than than the Medicare side. That's just a personal opinion,
Okay, we'll change it,
personal observation.
we'll change it to commercial and all other.
If I may, that's
Oftentimes,
all we
hang on
look
a
at,
minute.
Marlo. We look at the other side, because that's, we
Well,
can't do anything about
I'm
it.
not saying you don't look at it, it's just that we've labeled it something and it's almost derogatory. And, I think it could be more positive by saying, hey, we need to get more people to come to our facility. Whether it's Medicare or not, I realize what the number is. I think I've looked at it long enough now that I understand it. But I think the positive side of it is we need to grow our business in commercial. And that's all I'm observing, and I'm not complaining or telling you not to do anything. I'm just saying that seems more negative than if we're looking at how do we build our commercial side? How do we get it back? And if it hasn't left, then how do we make it back? So that goes up, because then it changes that mix, just as well as all of us getting older, not all of you guys, but some of us older ones getting older. And so it was just a thought and an observation about where we focus and how we think about it, because I think, I don't know, I am to blame. I'm one of those Medicare mixes. And you get to subsidize me. That's all there is to it. I don't know that I wish it was different. I guess I've been paying into it still paying into it, excuse me.
I'm the
So-
same. I'm a commercial insured that will shop for what I can afford.
And I think that's great. And so we need to focus. It's just an observation, Dan. I don't mean that as derogatory to administration or management or anything. It's just an observation. I keep hearing this and I'm going, well, there's not much we can do about age. I would have changed that years ago. I've been able to do something about age.
And that's fair.
I feel it every day. So I'm just thinking a different focus is all.
How hard is, Mr. Chair, how hard is it to see, like, I understand that the mix, it comes by percentage, but like number of encounters? Did Medicare change by hundreds or did commercial change by hundreds and Medicare stayed similar? Do you know what I'm asking?
And you should have seen those charts that are.
I don't think
I just a short answer, like, not really in depth. You know what I'm asking, right?
Scott certainly has those answers.
Yeah, it's both. Well, since you're only measuring two things, right?
Yeah.
They're inverse of each other, right?
Yeah.
So
Why don't you send those graphs that I've seen? Did you not send those to all the board?
I send them to you, you want them, but
I didn't push them on, so why don't you send them to the board just so that they,
I'll
I
share them right
think
now.
you saw some of the finance, didn't we show them the finance committee?
But I think wasn't it last month where they showed us that the actual Medicare dollars, they increased. So this winter, when all of a sudden we started talking about this Medicare mix, like those Medicare dollars jumped. Now that's gonna happen regardless of if the commercial decreased. When those dollars went up, that showed that utilage went up with it. We went over that last month or the month before.
I'm just saying, if you have 10 patients and 5 of them are Medicare and 5 of them are commercial or whatever other version, that's a 50-50 mix. Did we have 6 encounters or 10 encounters and 6 of them were Medicare and 4 of them were commercial, or did we like lose so many commercial? That's what I meant.
Depends on the month.
Yeah.
Some of them can go, they go up and down and cross each other, those lines, right? The percentage, one can be 40% and 60%, that'd be 50-50, then 40-60 the other way.
Like this month, I assume Medicare went down a little bit.
In May, it's jumped up to
May is
50%.
And May is jumping, so-
Last month, it was down to 45. 44.
Yeah, just 45.
Yeah, what we'll do is, these are the graphs we can send out. What we'll do is
This helps.
You guys ought to know this if you haven't seen it. I remember
haven't
seeing it at finance committee and we'll share them. There's nothing, it is a mix in the sense that sometimes it's Medicare and sometimes it's commercial.
If you look, I'll show you just one. I'll give you these. If you look at this bottom graph here, this shows over a 24-month period, right? And
You're talking surgery volumes?
surgery volumes as a percentage of total. So again, measuring two numbers, there's only two, equals 50-50, or they go up and down. The orange line is other than Medicare payers. right? You see some of those are very high in terms like, look, back in 23, October, it's up 60 plus 65%. But those, as you go over time, those numbers are getting closer together. You can see the seasonality too. When the wintertime, you can tell when it is, right? And you can tell when the summertime is. But those numbers are getting closer together.
So when the two lines cross each other, that's when it's about 50-50?
Yeah, when they're touching, or like in October of 2025, the Medicare number went above the other payer number. So that's when we started to see, whoa, I hadn't seen that much before.
I think I can articulate my question better. Patient encounters.
That's what that's.
That's what it is.
That's not dollars.
These are
That's
volumes
encounters.
only. These aren't dollars. These are just volumes.
These are.
Okay, I'll study this.
Yeah.
Then
I
I'll
think, yeah, I'd love to have your,
ponder on what I'm really asking.
No,
It should be pretty easy for me to look at a chart and be like, the same number of Medicare really does exist, but there was attrition of commercial, or I should be able to say everywhere was growing. And I think you're telling me it depends on the time of the year and what
It's both.
department.
What we're
Yeah.
saying is it's both.
I'm gonna have to spend a minute.
it's
on looking at
department, it's time of year, but they are tracking it very extensively.
Yeah.
But nobody disagrees.
that. No, I'm not, yeah, I'm
That
not,
commercial there's out migration.
yeah.
And nobody, but we're also saying,
Did we have a huge increase in encounters? Is it the same people with multiple visits? I kind of want to get my eyes on that. I haven't seen that. I'd like to look at that.
Jeff, you got a question?
Well, maybe more just a comment, because we've maybe taken a little bit of a departure here, that from my perspective, I'm not sure that it makes a difference if I call a zebra black or white when it's a zebra. And I'm not, I think when we talk, so for me, the emphasis is on mix, because I think it's just like we don't necessarily want to make the Medicare the scapegoat. I don't think it's always helpful for us to blame pricing as the scapegoat either, because as I understand it, one of the other challenges that we're dealing with from a mix perspective, and I can just see it with my own employees, I'm seeing you get more and more people who are exiting insurance because of just of the cost of insurance, let alone the cost of the care.
There are a lot of factors, I agree with you.
And that's something that the hospital can't control either. And so I think you have a problem if you try to just look at one of those particular areas.
So the compromise is mixed.
To me, it
it's
is.
just mix. Don't say Medicare, or don't say commercial, just say mix.
I think it's the blend because it doesn't help us to just put our head in the sand to
You're right.
say that Medicare isn't a problem when I think the encounters show that it clearly is part of the problem. And I think you could also say that the number of those that are exiting the insurance ecosystem is a problem. And I don't know how we address that. But if both of those are problems, then it falls on the prices that we have to charge to make up the difference. So I think they're just so interrelated. Personally, I'm not sure it gives us any benefit to eliminate one or the other from the conversation. We have to just focus on.
No, I think we need both of them on there. I just want to take a positive spin on it.
Sure.
Anyway, what else, Scott? You had other comments on financials?
I'll get to these.
I love it.
They're just, pardon the shot. There's one of the departments, it's not small, the PT teams. This is the most wild ride over the past, look at this, on this column here. You notice how many times the Medicare goes above the commercial. But then there are commercial times that are just as far above the Medicare volume. So it's changing all the
It's a
time.
blend.
It's a blend. So I'll get them to you. But these are volumes, not dollars, so it kind of shows you that.
Anything else you want to highlight, Scott?
No, that's
Statistics or anything? I didn't see anything
What's our base cash on hand as of today?
as of today.
as of today, we're 27.2.
Thank you.
I mean, if it hasn't been readily apparent, we've been cruising right in the mid-20s for several, months. So we're not losing, and we're not making ground either. So we are living within our means that way, but we're not building anything. We have a plan to do that, but that's where we're at.
Thanks, Scott. Any other thing
Plan
on
adjusting.
consent agenda? Go ahead.
Plan adjusting for the payments that we are experiencing currently.
Yeah, that's maintaining that during this period of extreme cash, remittance pressures.
Yeah.
Being able to maintain that, so between costs, revenues, expenses, so.
Consent agenda, any other questions, I guess, since we're talking about it? And I need a motion for the consent agenda.
I make a motion that we approve the consent agenda.
Second. Abby, got a motion by Clint to adopt the consent agenda and a second by Abby. Any further discussion? All those in favor?
Aye.
Any opposed? Great. Unfinished business, as I understand, the uninsured payments policy is still being worked on by management, and we'll come back to a future meeting.
A motion to table.
We need a motion to table.
So I make a motion that we table the uninsured patient payment policy until next month's meeting.
Yeah. We're trying to
Is that gonna be enough?
Yep, I think so.
Yeah, I'm more comfortable now that I know, I know what that is, just like I was just.
Are you seconding with all that?
Yeah, I'm seconding that.
Okay.
I'll second that.
Clint moves and Abby's gonna second that we table our finalization of the uninsured patients payment policy. Any further discussion? All those in favor?
Aye.
Any opposed?
Could we ask what the headway on that? Or you have on it, or just not ready to go?
That's the budget.
I think,
Yeah.
I think it's really just the time constraints that we've been under and everything else.
Okay.
That's.
Yeah, you want to do it right.
We do.
And really think about
Nobody's been asking them any questions, so they've had what? Okay, we're gonna switch our agenda just a little bit. Cole had to leave for a minute, so we're gonna move our item A under new business, finance and construction a little later in our agenda. So I'm gonna jump to the quality committee. Would you give your report?
Maybe talk slow, see if he comes in. My report, I'd like to point out Cash Pennington got the Good Catch Award. He was working with a patient in physical therapy that had his stroke that went in his face. Not the telltale signs, but picked up on that and got him referred to him and made a big difference on the outcome there. So that's pretty incredible. Another trauma survey that Tori had to manage. This one was more anticipated. It's one that we do participate in every 3 years. So this one wasn't catching him by surprise, and it went really well as always. Afton is recertified as a level. What?
I said community trauma.
And Alpine is receiving PR, and that's our plan for now. There'll be a lot we have to.
Tell us the difference on this. So Afton is a what?
Community trauma.
Community
Hospital.
trauma hospital? It's not a level 1, 2, or 3, or is that after community?
No, the
Do
state
I mix things up?
No, the state of Wyoming doesn't do levels. So the lowest is the trauma receiving, which is Alpine.
Okay,
And then we're the next level up here in Afton, which is the community, and then it goes area and then regional.
It would require a legitimate ICU to be the next level up. So where we're at right now is where we want to be and where we're growing to and may change that.
Okay.
So that's impressive. And we had a nice discussion around EMS. Ryan reported, and we do get the status zero. We decided that it would be helpful to know like the duration of status zero. We know that we don't have any units to send it, and they've also considered tracking when we're down to just one unit, how close we were to having multiple status zero. So it's more of a manual type of a pull. It'd be a little bit tedious, but just looking for some information as they're considering all options to improve EMS. And just to reiterate, about half of the calls that EMS take are unbillable because the codes require transportation. So if they come, they do all their work and their assessment, they say, I don't want to travel, unbillable. So nothing they can do about that glitch in the system.
so if we treat them on site and don't transport, is that what you're saying?
Not billable.
Not billable?
nothing in their power. It's totally unbearable. And I think that's a heavy lift. That is something hard to combat, and I don't even know, that's like seems like a national situation. And
So what do we
followed
do,
up
ask for a credit card ahead of time or
No.
something? On site?
No, it's like, do they automatically go out on those? Do they wait for the police to say, are we wasting precious times if they don't just head automatically? These are not solutions I'm coming up with, but it's definitely something that everybody's thinking about.
Sometimes what happens is bystanders will make a call for somebody that has been in an accident.
Or not an accident, they're sleeping on the side of the road.
Yeah.
I'm really worried about that guy, you should go check on him.
Show up and, what are you talking about? I'm fine. So that there are all sorts of things that come up that we either treat or don't treat and don't transport, so.
Or they really may have shown up, really taking care of a situation, and they're always the recommendation that they have made contact with the patient. They're 100% of the time recommended that they be seen at our facility. Not just they can recoup the transport fee, but that's what Ryan said. I followed up with a question. He said we always recommend that they come to the facility. And this has been the number since I can remember in quality. It's like 50%. People are like, oh, we pay for the ambulance. Like, that's not the problem. It's not getting reimbursement for the ride that you took. It's that there were half of the time people didn't take the ride. Unbelievable. So, be thinking about that. And just, again, kudos to quality. Everybody's looking at ways to, maintain this high level of care and hold themselves accountable for, anything, see if we can process improvements for when things don't go perfectly, and they're always pushing the limit on the numbers. So I'm always really proud of what the hospital's doing. That's my report. Any questions?
Questions for Abby? Thanks for the report, Abby. I don't think we had an ethics meeting, so that's next month in June. Is that correct, Andrew?
That's right.
And the foundation report, so hopefully Sean is going to be able to get here, but we're going to be talking about that. So let's just start into that. We're going to start with a presentation from John Getler. Is that correct? Did I say it right?
Getler.
Getler, okay.
Pizza, I just say Getler. Or I use my wife's maiden name, which is Smith, and that's what I use.
So just so that you have a background on our foundation discussion here, because we do want to discuss a few things. One, John's going to give us a presentation about fundraising, and then we're going to talk about one of the questions the foundation had at their meeting was, what do you want us to look like when we grow up? Now, that's my statement. It wasn't quite that way. It was, what do you want the foundation to do? What are the goals for the foundation? And so we're going to talk about that in foundation strategy. And then we also have a discussion. Hopefully you've read Jeremy Larson, the president of the foundation, sent us a letter as well as other documentation of some research he's done on other foundations in the Rocky Mountain area. So, John, if you'd start us off, then we'll go from there.
Yes, thank you, Mr. Chair, and my thanks to all the members of the North Lincoln County Hospital District Board for the opportunity to be with you. I've been in the fundraising business my entire life for 39 years, 26 years in Columbus, Ohio. Moved my family, a wife and 3 kids out to Teton County, Wyoming 13 years ago. I think this is a noble profession. I'm very proud of the work that I've been able to work on over the years. I believe in joyful giving. It'll make my smile. There's no arm twisting allowed. There's no persuasion. There's no guilt. We present an opportunity to a potential donor to support the nonprofit initiative that we're presenting at the time. And they either say yes or maybe or no. And it's just the way it works out. In September 2013, I was one of 2 final candidates to become the president of St. John's Hospital Foundation. On my way to the airport, I signed a non-disclosure agreement, and I read this best practice for a healthcare a foundation presented by the Greenwood Company. They are out of the Bay Area. The hospital foundation did make a good decision and asked me to become the president. I moved the family out. And over the course of the next 8.5 years, I worked very carefully to put in place what I now call the 4 pillars to create a best practice healthcare foundation. And that's what I want to do with all of you. I read the plan 3 times on the flights from Columbus, Ohio to Jackson, Wyoming. I told the search committee I wish I had written that report. It's excellent. We began in, after I moved and got underway in 2014, we carefully reviewed and put in place the 4 pillars. And so the 4 pillars, what are they? Real quick, I just want to review them. We're going to have a foundation board, an employee, and a physician giving program. We're going to approach the internal economy, if you will, that exists within the walls of the hospital and look to see if they will demonstrate the importance of the foundation, the importance of charitable giving by making their own contribution. The largest and most significant effort will be an employee campaign. We need to be very careful. You can't have managers approaching their direct reports. That would be arm twisting. You heard me. We don't do that. And so this needs to be joyful. This needs to be, I like ice cream. And so I would invite employees to come to 15-minute presentations, maybe here, enjoy an ice cream sandwich on us, and learn more about what we want to do in terms of, what's the case? Why do we want them to support the project? What the Internal Revenue Service discovered in 1941 is that if you use payroll deduction, an employee doesn't even miss the contribution. And so we asked our employees at St. John's to join the half-hour club or the 1-hour club. 1 hour or 1/2 an hour per pay period. We had 26 paychecks a year. We were paid once every 2 weeks. And so that 1 hour can add up. But it's also meaningful to emphasize participation. And this elected board is tricky, just like the elected board was for St. John's, but we'll certainly lean on the foundation board, and I'll look to admin to be as supportive as they hope the employees will be. So this works. Pillar number 2 is called the Grateful Patient Program. Bob Greenwood tried to convince me to work it via direct mail, total flop. You get surveys, you get bills, you fill up the post office box. So direct mail did not work. We went directly to the physicians and said, hey, when you have a patient come back to the office and say, how can I ever thank you? We teach the physicians to say, may I have a member of the foundation staff contact me? Then as we contact the patient and we hear the story about their gratitude and what went so well, we ask if we can tell that story. And we loop back to the physician. And so there's a really wonderful little win-win loop in there where folks start to feel really good. The website and all of our reports and our marketing efforts start to report on these grateful patient experiences, and it just builds upon itself. And by year 2 or 3, it gets to be a really, really self-fulfilling kind of a program. Number 3 is the Friends of the Foundation program. So pillar number 3, the Friends of the Foundation program. We started at $1,000 at St. John's. We could start at any level we want. We could start at 100. We could start at 250. We could just start with those that had made a gift to the foundation. We worked with patient admitting and the software to start to put into the patient registration software a star or some designation to denote that this is a human being that has made a contribution to the foundation. When they're checking in, the patient admitting staff has an opportunity to say, oh, And by the way, thank you for supporting the foundation. I can't believe what magical words those are to say at check-in, thank you for supporting the foundation. It just lights a person up. We found and landed on 3 Friends of the Foundation's receptions a year. Of course, one during the month of July. We had one in the fall, and then we had one for the holiday reception. We started out, the only option we had was to go to the clubs, so 3 Creek, the Pines, and we invited the Friends of the Foundation. No paddle raise, no arm twisting, no even asking for money. We expressed gratitude as often as we could, and then we would have about an 8 to 10 minute presentation from the new chief executive officer, from the new cardiologist, from a new physician. And so people started to really come and bring their friends to hear more about what was happening. When they went for the hike the next day, they got to tell all their friends about, hey, there's this fantastic new cardiologist I just met last night. And it just, again, this became by far the most successful program that we had at the St. John's Health Foundation. They've subsequently raised it, or we actually raised it up from a minimum of $1,000 to $2,500, and they're now at actually $5,000. And I'll bet there's over 450 Friends of the Foundation. So these are recurring gifts that are coming in every year, and that's the expectation. The magic of a recurring gift is that if a human being makes a charitable contribution to a not-for-profit organization 3 years in a row, they like what you're doing. And they're going to continue to give unless that nonprofit organization screws it up. And we all know a lot of nonprofit organizations are very good at messing that up by not saying thank you, by not expressing gratitude. But the Friends of the Foundation can be a recurring program. We had one for the Alpine Clinic campaign, which I'll get to in a minute. Number 4 is the annual appeal and the business and community outreach. We got to a point at St. John's where we did a pretty elaborate kind of impact report. It grew to about 28 pages, which was, I think, a little untenable. But the key was in the back, you listed the donors and you listed the donors by amount. And my favorite story there is the Jazz Arts Group in Columbus, Ohio. If you make a gift of less than $100, they categorize you as a cheapskate for jazz. And every event you go to, from the stage, they said, you don't want to be a cheapskate for jazz, so you can do a little better. So write a little bit for check, something above $100. When we moved to town that first year, I had to have a candid conversation with my wife, Valerie. And I said, I can't go to the post office. It's too hard for me to work so hard to get this annual report done, to print the 1-page appeal letter with a business reply envelope. That means no postage is required. That's essential. You can't ask your potential donor to look for a stamp, for goodness sakes. Just drop it in the mail. But for me to go to the post office and watch everyone stand in front of a recycling bin and just rifle every single piece of mail that they got into the recycling bin made me realize how hard it is to get that annual appeal read, to go home, to write a check, to print the business reply envelope back into the envelope and come back to the foundation office. And so I'm here to tell you, this will work. If you get it out, if it hits the Monday after Thanksgiving, it can't be the second week in December, but we got to a point where we were receiving over 4,000 gifts during the month of December. We started at about 400. And so we went 10x on the number of gifts that we received. And it was joyful to be in the foundation office in December, to open the mail, to see just this outpouring of support. So that's the 4 pillars. By the time I left in 2022, after 8.5 years, we had built a fundraising machine at the hospital foundation. Yes, we had to administer the program every year. But now St. John's Health Foundation is raising $6 to $8 million every year. Now I have to back up to say St. John's Health agreed to pay all the expenses of the foundation. And for me, I could see the visible gasp when you would tell a potential donor that 100% of their gift was going to their desired program or appeal. Magic. So for the early years, I had a mandate to add a staff of 1, and we grew to a staff of about 4.5. But if you read in the paper, St. John's Health lost $19 million last year. And if it weren't for the property tax and the foundation, they would have had a material loss. We can do this. In March, I volunteered to come down. Mark, Jeremy Larson, Mandy from HR, and I were the interview team. We had 3 great candidates. They each brought something different to become the next executive director of the foundation. We were lucky to all unanimously agree that we wanted to work with Allie Nielsen. She's organized, she has enthusiasm and energy. Her HR background is actually really good for the 4 pillars. That's the kind of stuff that I think can lean on that. We've only had a chance to spend a couple hours together at the foundation board meeting. But I can tell we're going to work together really well. We're going to be a heck of a great team. So I worked with you folks and the foundation on the Alpine Clinic campaign. We did okay. I had higher goals and objectives, but we had 3 or 4 important assets. We had Dale, we had Jeremy Larson, we had Mike. And thank goodness we had a guy named Rex Dornbos from New West Building. Rex was willing to introduce us to many, many, many residents of the air park, where he had gotten to know them by constructing their home. And we had over 24 of those that became nice donors to that campaign. They had hanger parties every Friday in there. I had no idea. I can't believe I was in charge of the St. John's Health Foundation. I didn't know there was an airport down here. So that's kind of the model we had in mind for the Friends of the Foundation events. Are that kind. We had Dr. Gonzalez, Mike spoke, and you spoke for sure. It was really well done. And if you can just start to think about when that starts to take hold and captures, I think it can be really amazing. So I put a proposal in to come down to work with Allie, to work with the foundation board, to put the 4 pillars in place. This first year, we're going to work really, really, really hard to have contributions meet expenses. And then by year 2, I anticipate that the foundation will be a positive black ink producing asset to Star Valley Health. I'm absolutely convinced that we can do this. If you read the report from Jeremy, he made some excellent, excellent points that for rural hospitals, the foundation is becoming essential. And so I'm asking you to take a little bit of a longer view here. This is, if we would have had Friends of the Foundation and the Grateful Patient Program in place when we ran the campaign for the Alpine Clinic, we would have done a lot better. So this is an opportunity. Mike is articulate that foundation's a 20-year-old and hasn't really found its purpose in life just yet. And I think working together, we have an opportunity to make this, with the help of Allie, a really exciting growth period, John, for the foundation.
Got one question here. Going back to the significant role of the St. John's Foundation. Is their foundation, do they only contribute to the hospital in capital purchases, or can they actually subsidize the operational losses of the hospital? Do you know that?
Yeah, sure. So we're a little different than you guys are. The St. John's Health Foundation is a separate 501c3. They have bylaws that allow the hospital foundation to support programmatic initiatives like diabetes, actually helping the patient. So they do contribute to outside, entities or people. The Women's Healthcare Fund can be accessed by all members of the community. We stopped short of wanting to actually support operational costs, but in my last year there, we had a major gift come in, a planned gift to the hospice program, and we couldn't find enough hospice uses of funds. And so we actually agreed to fund the hospice staff. So, we started to pluck away, and maybe not, we didn't like the visual of the community being under the impression that we were supporting operations, because that's a tall order.
Yeah.
But we were able to pluck off components.
Certain expenses
Uh-huh.
that met the charitable mission of the 501c3.
We had a ton of restricted gifts. And so spending restricted gifts can be challenging. And so we had committees on the board that thought creatively about how can we spend the diabetes fund? How can we spend the hospice fund? How can we do a better job? Money flew in the door for COVID relief, and I got a funny feeling that's going to be sitting in a restricted fund for years to come now. But with some creativity, I think you can make that happen. So I watched your April board meeting. I heard the finances. It's not fun to come up as a development professional after the finance report. I know you're in a really tough spot. But I have enjoyed working with the foundation board and staff, Mark, and now I hope Allie. I've been at this an awful long time, and I know we can do this. I think we can make the foundation a top performing department, Star Valley Health, within a matter of 2 or 3 years. Yes, ma'am.
I have a question. So we heard this same, we had you come and you did the same thing just a few years ago. I guess it didn't work. So what's going to be different this time that's going to make it work that didn't work last time?
Yeah, because we didn't have the Friends of the Foundation program in place. We didn't have the Grateful Patient program. You didn't have employees, except for a handful, contributing.
Do you think that's going to work this time? I mean, it's tough right now. I mean, I work at a bank, and I'm a branch manager, and I mean, it's a tough time right now. People are having a really hard time, and I just don't know. I know you're saying these things are going to be in place. It's going to be better. We're going to have all these things in place, but I don't know. It's just, to me, it's a really tough time right now. I don't know that it's going to be that much, it's going to help, or that people are going to be willing to give more money right now than they were several years ago. That's just, I don't know.
Well, Mike was with me on a bunch of the tours that we had for the Alpine Clinic campaign. We didn't do as much in town as I had hoped we would. We kind of got in the habit of just starting to meet with the residents of the air park. And candidly, the contributions were missing a zero. It was, I think we were hoping it was going to be a $50,000 multi-year pledge, and it was a $5,000. We were maybe hoping it was a $100,000 pledge, but every single one of those residents, we want to re-interact with it. There's some prominent new folks that have moved into this, Lincoln County. And I think if we get organized and we have a sustainable, systematic approach to engaging with them, it's just getting that first gift and then the power of that renewal. And if we're good stewards of that gift, be it $100 or $1,000, then if we can get to year 3, we've got a donor for life.
Can I touch on?
Please, yeah, jump on up here.
Everyone, again, I'm Allie Nilsson. I feel like one of the big things, and I've heard Mike bring this up in several of the board meetings that we've had, but one of the differences with previous people who have held this position is they were also over a lot of the events that the hospital did. I've been very fortunate. I've worked with the hospital for almost 3 years now, and I was able to work in the same building as Mark Taylor. And I can tell you that one of the things, if we go this direction, is that this position would be exclusively focused on the fundraising aspect. I wouldn't be involved in the parades. I wouldn't be involved in the rodeo. I wouldn't be involved in the fair and a lot of these events that took a majority of Mark's time. I can't tell you how many hours he spent building cute little Christmas parades that could have been used in a significantly more effective manner for the foundation during that holiday season to fundraise. And so one of those big differences and a great opportunity for this foundation and for the board going forward is if you go to that generative thinking and generative discussion is this position will be exclusively dedicated to the foundation with the goal of raising funds, of course, but also I know one of your big concerns is the relationship with the community. And I love that John was able to touch on the grateful patient. I know Tori sent me an email when I was first brought up as a candidate for this that had been accepted for that grateful patient program. And once you get telling those stories, once we can publicize grateful interactions that patients have had that are friends, that are neighbors of the community members, you're going to see, however slow and methodical, a turn and that growing appreciation when we know that Mindy had a great experience at the hospital and donated $20 as a thank you for that. Or when we see opportunities from friends and neighbors that have had those same experiences. So again, there's some very big differences that are going to happen with this position, and I just wanted to share my input on that. Thanks, John.
Well done. It's been my experience working with not-for-profit organizations for close to 40 years that when you have a marketing and development director, marketing's way more fun. It's hard asking people for money, so they spend 90% of the time on marketing stuff, 10% of the time on development activities. It just doesn't work. So I was thrilled. In fact, I wasn't even aware of this kind of disconnect. So we have tweaked the job description, and Allie's absolutely right. It's going to be blinders on. I'm going to be down here a day a week. We're going to be talking probably every day of the week as we grow the program. I'm going to be coming giving Dan monthly updates. So if it's not coming together, to your point, Mindy, it's in my interest to tell Dan it's not going well. We're hitting some speed bumps, and then we for sure have said let's just go for 6 months and then really have a powwow. I could come back here for the December board meeting and say what's gone well and what hasn't, what has worked. As I said, I mean, Greenwood wanted to do the grateful patient via direct mail. That was a bomb. It flunks. I mean, just the hate mail I got back from people was insane. You know, you want me to build you a runway at the airport as well. And so, yes, it's a tough time, but the market's also at an all-time high, and those that have the means have enjoyed a really remarkable year. So I think we have a lot of folks that we can get right back to. I convinced Mike that he's not going anywhere. He's going to join the Star Valley Health Charitable Foundation as a volunteer. I hope that's still going to happen, Mike. I'm looking forward to working with you. Other questions?
Questions from John right now? Appreciate your presentation. We're going to be discussing. If you'd like to stick around, you may have comments.
Okay, that sounds great. Actually, I'm chair of the St. John's Episcopal Church vestry, and I got about an hour and 25 minutes to get
Then you'll make it if you hustle.
a board meeting, if you don't mind.
Yeah. We
You can watch
appreciate
it
you
on
coming,
repeat.
John.
Zach.
Mike, do you want to follow up with anything? As the current director, I guess, is that the title?
Mr. Chair, board members, I believe this will be the third month in a row you've heard from me regarding the foundation. I'm not sure there's anything else I can tell you other than I believe in the mission of the foundation. And I am happy to answer any questions regarding the current situation of the foundation. I've provided each of you with a statement of income and expenses over the last 5 years. And just to clarify that, the 2024 year is fiscal year 24, so it goes through June 30, 25. So you can see the income and the expenses that have been raised and expended by the foundation. Short of repeating some of the things you've already heard today, I truly believe that this foundation needs to focus solely on fundraising activities and not on marketing activities for Star Valley Health. I think that's maybe one of the only ways that it could be successful. And I agree with board member Lyman and her comments regarding it's a tough time right now for wage earners. But I want to be sure that we're focusing on the right people for joyful giving to the foundation. And that will take someone like Allie, who is willing to go out and find those people who are living in the foothills in Star Valley, who want to participate, who we do see in our hospital on occasion, that do participate and do take and are Medicare patients, and have the ability and the means to contribute, and especially with their good experiences with John's 4 pillars that he commented on, we can build on that and offer those opportunities for joyful giving for those people who do have means in our valley. I certainly don't think that there's an expectation that we would get everybody from Star Valley to donate to the foundation. There's no expectation that every employee will donate to the foundation. But those who feel like they can give should have an opportunity to give. And if they believe in their employer and they believe in the opportunity and they believe in this organization, I think we'll be successful there as well. Now, regarding the request to this board, which is to fund the expenses of this position, so that when we do go to potential donors and givers, that we can say 100% of their donation is going to the cause. I think that's a really important thing. And as I mentioned to you last month, it really is a pay me now or pay me later thing. You pay some now to get more in the back end, so you don't have to pay the expenses in the back end. It is the board. This board is taking a chance on that. There's no question about that. But I feel like this is an important way for Star Valley Health to continue. And I don't want you all to think that this isn't a marketing opportunity. It's marketing in its own way. It's not newspaper advertising, and it's not the organization sponsoring something at the fair. But it's Allie and others in the organization who are making contact and telling the stories and being able to share with our community the good things that are going on at Star Valley Health in a way that makes it a philanthropic opportunity for those who do have means to feel like they can support and be part of this organization. So short of anything more, you've heard me say this before. I believe in this opportunity for the organization to advance the cause of the foundation. And in the long run, it will fund many opportunities for growth here within the organization, whether it be equipment or whether it be programs. So just for your information, we do receive donations from various individuals and organizations throughout the community, and we fund women who are either uninsured or underinsured to be able to get their mammograms. That is funded through the foundation, and we have I don't know the exact number, but they're in the dozens of women who are able to take advantage of that program through our foundation, and that is all funded by donations to the charitable foundation. So I think there are opportunities within the bylaws and within the articles of the organization to be able to support those kinds of programs that would support Star Valley Health in a way that I think is good for the community. So, thank you. Any questions?
In reading through Jeremy's and being at the last foundation meeting, it seems to me like foundation board is asking our board 2 questions. One is the one you just brought up, who pays for what? And 2, I think the other one was, what direction do we go in organization of the foundation? I think he definitely in his letter put out, we want to do it, the case that Allie just made, or do we just do the fundraising activities that we've had in the past? And am I understanding those 2 questions right?
I believe you're right, Mr. Chairman. I think the chairman of the foundation board, Jeremy Larson, his comments, and you've probably all had an opportunity to read it. He and I have discussed this at length, and we both are of the same feeling that do we take the next steps, or do we just continue to go the way we're going right now with minimal fundraising success? Unless we really focus on it. With John's help, we focused on it and raised in excess of $500,000, as you can see by the numbers there.
It was the 2023 call, is that correct?
Yes.
When we were doing Alpine?
Yes.
Now, didn't we have, was it the Greenwood group before that we played around with?
We did have, the same gentleman, Mr. Bob Greenwood, did write a report for Star Valley Health in 2018.
That's what it was.
When Bren Lowe was the CEO. Bren had lots of success with Bob's program in Livingston, Montana. And Bob's report came back to us, and we've been able to, utilize some of that stuff, but we never implemented a lot of it either. And I think the main thing that I'll just speak from my perspective as the current, albeit poor, charitable foundation executive director on an interim basis. It takes time to run this, to do this, and I have not done a good job because I've been spread all over various other things. Mr. Taylor, he experienced the same thing from the marketing standpoint, the community relations, and the fundraising. It's a lot easier to do that easy, fun stuff than it is to do the hard, will you make a contribution to our facility and why? So I think that we're at a crossroads, as Jeremy said in his letter, we're at a crossroads. Do we stay the way we are, or do we take the next steps to really become successful? And I do believe that with John's help previously, of course, we had a $2.5 million goal, but we raised $500,000. That's a lot more than we ever raised before. And we didn't really implement the 4 pillars that John spoke to us about. It was really kind of just a campaign that we were focused on. It wasn't the whole program. So I truly believe that if we implement the whole program, and give this a 6-month opportunity to see progress, if this board would consent to doing that, I think we can really show some success.
So as I've thought about this board and I attended the foundation meeting, I think my last statement was from an optics standpoint, I've kind of gone 180 degrees after thinking about this and looking at it, listening to John today too. I don't think and I've asked the foundation person for probably since I've been on this board. I went to a convention some years ago and they had a formula, and I tend to like those, and they said, how many dollars per donation does it cost to to get a donation. And I could never get that answer out of the administrations in the past 16 years. And I've always wondered about that. But I also recognize even back in Joe Johnson's time, it was a split situation. He was doing many things. And along with that, I think it's been that way clear up to where you are. And so my observation, I guess, after looking at it and studying it, is we need to give it a chance. I think I don't have a problem. I mean, it is pay me now or pay me later. Don't disagree with that. I think the hospital ought to fund the position. And we give it a 6 months try. We bring John on to mentor Allie and see what we can do in 6 months and see how it's going. And I don't think we've actually given the foundation a real opportunity to grow, at least in the 16 years that I've been here. And I think you are right. We're probably at a crossroads. As you look at Jeremy's report, or as I looked at it, there are those hospitals that are just doing fundraisers, and there are those that are actually getting donations, contributions, because somebody had a success at our hospital. I think it could do a lot in all areas. And I think we need to find out where, I think there are giving people out there, but yeah, it's tough to ask the big questions. And so that's my observation and my recommendation. I think the board, I've probably turned 180 degrees from the last time we talked about it. And I would like to support that. Both we pay and we have the direction of the foundation board be more like what Allie just painted to us. Clint?
So yeah, I agree with everything you said, Marlo. I'd caution against the 6 month mark. I mean, based on what the last gentleman just said, you know, if somebody gives for about 2 years or 3 years, much gone at that point. 6 months seems a little.
And I don't know, we're gonna go just 6 months. I think what it is a report in 6 months to see how we're doing.
Yeah.
Is what I heard. Is that what?
Thank you. Yes, I would support that.
Is that what I heard, John? You didn't leave.
We won't, well, I mean, Mike was like, it was like the teacher watching the student. I'm so proud back here. He's preaching the gospel to me. It's just incredible. In 6 months, we're going to know and have a full report back to you on how we're doing. We will identify strengths of our relationship and what we've been able to build and get in place. And I'm certain, based on my experience up at St. John's, that we're going to have some things that didn't work as planned. Didn't work the way we diagrammed them on the chalkboard, and we'll have to take corrective action, but we're going to know a lot more in 6 months than we do now. I actually have a 12-month proposal in front of my hand, where I hadn't anticipated a very active role.
Does that answer your question, Clint?
Yep, thank you.
Other comments from the board? Other ones? Cool.
So I guess, one of the things for me personally with this decision, I want to see value add. And at the end of the day, as we look at, hey, what would we raise if we would have ran some sort of campaign just ourselves versus go full out? The hard thing is I don't know that anybody can answer that question. But for me, that's what's important there. Could have we raised $500,000 before without having additional out? Maybe, maybe not. That's where I'm sitting there saying, okay, what's the actual value add and what's our net gain after expense, that type of thing. One of the things, I guess, as I listen to this and outside of the decision, I would, we talked about zeros and things and this and that, but I will say that there's a lot of people in this valley that are very passionate about Star Valley Health. And, they may not have the ability to write an extra zero on those checks. However, they may be a very good springboard to somebody that does. And so just, and I know you guys already know this and that type of thing, but I think that, you know, those people that are very passionate, that know Starlight Health have been here, have, you know, been and have watched Mike go through the positions here, right? But you know, those are the people that are passionate and can, I think, can really help out. So again, I'm not necessarily opposed to anything.
Did you see this? I was just noticing that probably in the Alpine campaign, our ROI was pretty high. What we paid for it. That was the one year we went over 150,000 for just contributions.
There's your answer on what it costs to get $1. It costs 50 grand to make 5. So it's 10 to 1.
10 to 1. That.
You're just saying from their numbers.
I haven't found those returns in my investment portfolio. but maybe others can. So anyway, I'm just pointing that out is that I think it was successful. Was it as successful as we hoped? Obviously not. We had a much higher goal. John, we really appreciate it.
Thanks, John. Thanks,
John.
And so I just point that out as I think we did try the model for a short period of time and it was actually very successful. And so that's when I saw these numbers that I asked Mike for, that's another thing that kind of changed my perspective on this. So, John,
I was at the meeting, blindsided by the whole thing, so I'm not aware of what's going on around me. But when I got in there, the feeling I got from the board there is they're waiting for direction. They almost don't know what to do because the hospital isn't sitting here saying, hey, help us with this, help us with this. There's almost like a drop in communication. And I think they're just kind of like not stoked about doing anything because there's nothing being asked. There's no direction. There's no like, it was just kind of there. They were there for a meeting and correct me if I'm wrong over there. Tell me I'm an idiot if you'd like, but it just felt kind of like a stagnant meeting. Like, what are we going to do? Like, we either need to close up shop, pass it on to somebody else, or we need to go. But they're waiting for that like next step. Like, what do we do to go? And I think the plan that they've come up with Allie, and either she's a hell of a good salesman or she's very confident in what she's doing. She's not worried about making money. In 6 months from now, we're going to fire her if she doesn't do her job, right? Yeah. So it was really weird going through the whole thing and just the emotional part of it and seeing what I really think that the board bringing Allie on, and like you said, pay now, pay later if the hospital pays for it. Then we get that claim of 100% of proceeds go to Starlight Health. Is it? I didn't. I don't care what it is, but it does. They can say that now. And now if someone comes up, they say, "Hey, whatever money we're trying to do, Landing Pad and Alpine, 100% of proceeds go to Landing Pad." Great. But now they have a story. Now they have a reason how to do it. And now he's there helping with all that. It felt like everybody just kind of lost and wandering around. And I think that after 6 months, if it doesn't work, carry on. And we haven't really invested a whole lot in that point. We didn't build a new building. We didn't buy $1 million MRI machine. We didn't do a whole lot of big things. But I don't think it'll fail. I think it'll help a lot. Just the energy that came with Allie talking to them and then wanting out there was pretty cool. So if that helps you guys, push them on, I don't know. It just seemed to motivate them.
So a couple things that maybe to your point, like, you know, Search and Rescue sends out their letters every year. I call them the beg letters because what else is it, right? And it's always surprising because, you know, you get a lot of $10, $20, $30 checks, you know, to the point where people just do want to give something. They see a value there. So there's that. And then I would have to agree with Marlo and what's been presented and Jeremy Larson's thing, what Sean just said, that I think this position does need to be like a focused, like that's what you're doing. This is where you're not making a float. You are focused on the importance of, you know, because there is the joyful giving, but then even more important for another philanthropy, another ran one. The thank you stuff is like uber important, and that's something I didn't even think about. You know, being involved with the search and rescue stuff. He brought that up. Oh yeah, you need to send out, you know, oh man, thanks for this. Because you think, well, that's spending their money on a little thank you card that you send out, but it's a very important thing. So what I'm trying to say is, I think it is important to add a level of professionality and focus to this position, that this is what you are doing. You are honing in on this giving. That's it. That's what you're doing. So, very good.
Mindy.
So I have another question. So if, you know, Ally's gonna be doing this, focusing this, then who's gonna take on that other stuff? Are we gonna be paying another person to do all that stuff? The floats and the community? Yeah, I mean, how's it, if that person was Mark, or whoever was doing that, who are we passing that off to? Or are we paying someone, we're gonna hire somebody else, pay somebody else to do that stuff? I mean.
I may have the answer, and I feel like the board, when they get this direction, is they really are like, what are we doing? They're wanting us to say, let's do this, and I feel like with Ally there, being like, this is what we're gonna do, then I think that energy comes from the board, and that's when they get excited and like.
Right, and I can see what her focus is of doing the fundraising, but what about the
Who does
community
the other,
stuff?
is your
Yeah.
question, Mike or Ally, would you like?
I can address that.
Okay, and then we'll have Ally.
As the board may or may not know, Catherine Myers was employed by us, and she was specifically a marketing assistant. And that position, she left us not too long ago. That position has been filled again. Robin Finch is now our marketing specialist. I'm not sure what the exact title. She's full-time focused on marketing right now. And I think the intent there is if that's not enough, then we intend to ask our department directors to pitch in and help in those areas. As an example, the Star Valley Health Marathon. Every department director at Star Valley Health has a part to play in the Star Valley Half Marathon. And the organization and pulling it off and have various assignments. So I think that's the intent, that department directors will become more involved specifically either through assignment or volunteer basis to help with some marketing opportunities. So that's really, we haven't created a new position for marketing. This is taking in essence, what was considered a half-time foundation position, and turning it into a full-time foundation position.
And Trevor, maybe mention how we're absorbing, who to absorb her position in HR.
Yeah, so we're gonna miss Ally as a recruiter, but for recruiting, we'll have Layton, and we have a newer person, Katie, in our department. She's been with us for a couple of years now, but she'll start doing more recruiting, whereas before she was just doing kind of like the onboarding and helping with like paperwork and stuff like that. So now she'll do more recruiting.
That helps, yeah, okay.
Ally, did you have a follow-up?
Yeah, so I was just going to follow up and say a lot of the same things. I happen to currently work in HR as the recruitment and retention specialist, so I've been very fortunate to be a part of job description revisions, not specifically for the foundation one because again of that conflict there, but with the marketing. And just like Mike said, we've got Robin, who is now, unlike Catherine, who was also spread thin, marketing soul, and her huge background and what she's really phenomenal at is the marketing side of things. So she's going to handle all of the marketing. And then regarding other events and things, historically, and what we did last year for the Christmas was we had volunteers. The hospital asked and sent out an email for volunteers who came on their own time to help build the float. I know Sadie helped with that, Tori helped with that, Chris helped with that, Trevor helped with that as well. But so that'll be more of a volunteer base. And the thing that I really love about opening that up to additional volunteers within the hospital is it's going to pull together multiple employees in multiple departments. Again, part of my position currently is the retention. And so when everybody's able to come together, when you have ER techs working with IT, working with quality and patient safety, working with HR, we had an ER nurse that was there as well. But when you get everybody together working on something that brings them joy, that gives them a sense of not just accomplishment, but community, that's going to pull together and help again boost the morale within the employee and help us on that retention side. So I'm not sure if a set plan has been put in place with that, but based off of the previous experience with the hospital, I would imagine and I would strongly encourage that we move forward in that same capacity.
Thanks, Sally. Did I see any other hands?
Just a
Abby,
clarification,
before
so
we go
from,
back to Mindy?
you want to go first?
No, go ahead.
From the strategic planning, were we talking about Ally spending half of her time on the foundation and half in another job? And in the did I catch that? Was that the
No, it should
discussion?
be a full-time, it'd be a full-time foundation.
But like doing her recruiting job, was that a discussion at the time? That was the discussion. I just wanted to clarify. It sounds like we're abandoning that and we're talking about full position.
As I remember, it was a transition for her to finish out in HR and move to a full-time.
No, it was half and half when we talked about it at the.
That was one of the proposals. yes.
I just want to
Okay.
clarify, because I feel like we're definitely somewhere totally else.
Yeah.
But that's true. So we're talking about a full-time position, director, 100% of your efforts, a whole different job, 100% of Robin Finch's efforts is in marketing.
So that's my question. If we have
And John
Robin
Butler,
full-time, if we have Robin full-time in marketing, do we still need the Hinman agency as marketing?
Oh, absolutely. It's a whole team.
They've always directed it, I think, and
She's our local
What's her
point
name?
person.
Okay.
Yeah, there is a ton of marketing initiatives that not just Dan, but he has people remotely that also work on our team that you don't see or hear about. And Robin is just one of that person of that marketing team.
Okay. So I just wondered if we needed, him, as much as we pay him a month, and then we need another full-time person doing just marketing. It just seems like a lot, but maybe, like you said, there's a lot to do, so that's probably, okay.
Mindy,
Yeah.
as the auxiliary, we use the marketing for everything. Everything we do,
Through
for
Robin
our
or
bingo
through
parties or anything, goes through the marketing. So, yeah, and we had Catherine there before, so.
Robin will do that.
So, yeah.
do you have anything to say, Linda, from the board? You're the only actual representative.
Our meeting, of course, the other night was very, very good. A couple of things I do have to say is there's probably 35, 40 people in our auxiliary. And just like anything else that pops up, maybe we have 15, 20 that are really in there and really do things. To putting things on, Cole, probably our average age thing is 70. So, but to do our bingo parties, anything like that, we work on that for months and months. And of course, a lot of baking and everything. Yes, we love it. It's wonderful, but we make $2,500, maybe $3,000 off of our bingo parties, which, are wonderful and everything. But even our golf thing, and that's another thing, Mindy, we're here. We're in the pink.
Yes, right.
We love to go volunteer, and I just tell them, call us.
Yep.
We love to go volunteer. We're helping
You guys do
with
great.
the golf and with the marathon, and everything. So that does give them some extra hands. But putting these smaller things together are wonderful, but they're not gonna make all the money they need. And in looking at what we try to keep in our account, 20,000, whatever, most of that comes from the gift shop. Thank you all in here that stop in and buy something, but an awful lot of it comes from the gift shop too. But yeah, we're here to help, and we enjoy it, and I enjoy being on the foundation board, and we need somebody like this to go after the big stuff. Yeah,
So my other comment is you asked that question earlier, Dan, is I think we need to definitely steer away from the foundation looking for funds to help our operations. We ought to be able to handle operations on their own, and capital expenditures for specific items, Alpine furniture, whatever. I don't remember all the things we did down there. My art. Yeah, I think we need to have specific items that we're looking at that are more capital related. We ought to be standing on our own 2 feet without the foundation in our operations. And hopefully we're gonna get there, so.
Mr. Chairman, the
my only other
foundation
comment.
is ready to hear from this board about which capital items you'd like them to raise funds.
And I think what I'm gonna ask, I have no clue what is needed. And so, and I don't know that the foundation board needs what, so we need some recommendations for capital items, and maybe some of the board members do, but I can tell you, I don't.
Thanks, that comment.
Please.
Okay, so, you talk about segregating it, the operation side of things, which I think is great, but I think that you do get an impact when you start talking about capital items, because if we have a needed capital item, we don't have the funds to do it, it ends up in a lease, right? And so that's where it helps us with our operations side of things.
And I agree, it helps operations, but I don't think we're looking for deficit.
No, I agree 100%. I'm just saying that's the relation.
Yeah.
So, I mean, just keep that in mind that it does help us avoid.
Sure.
Putting more on these.
And helps us, replace our capital, equipment and things that we need. So,
Mr. Chair, sorry.
go ahead, and then we'll hear from Jeff.
Just clarification, I asked the question, I'm not intelligent enough to ask that type of question. It actually spawned from this gentleman.
Oh, okay.
So.
Well, we'll let him be responsible for it.
I don't want to have, yeah. So, go ahead.
Well, I mean, a couple of comments, just listening to the feedback from everybody. One, I think I'm also in alignment with the statement you made earlier that I may be changing my opinion around it. But I can't take the accountant out of me, so I'm struggling with some matching principles, like who's the beneficiary and they should pay for it kind of a thing. And so I actually was intrigued by this idea that if the foundation could support operating costs, and intrigued when it was suggested that perhaps some of those Medicare patients that are moving here for the retirement benefits and the good quality of care should be targeted for this. I mean, if we have a problem with our patient revenue mix, somebody has to pay for it. And in the Medicare space, I think you have to be looking at some additional subsidies to help meet those needs. And I think I was really intrigued with this idea that the foundation could potentially help address some of the operational revenue or operational expense challenges that come from our patient mix. So in that sense, I'd be more inclined to say, yeah, let's have the hospital pay for that salary, figure out a way to bring in some of those donations to help support some of the operating expense. And as long as what we're getting is greater than what we're spending, and it's going to help address some of the operational expense challenges that we have, all of a sudden I was like looking at this way different. But if it is sort of what we've traditionally done, capital projects as valuable as they are, or other types of programs that are maybe additive to what the hospital is doing, I'm probably inclined to suggest that the foundation pay for the salary, because it needs to be independent. And because I still feel like a little bit like that this patient revenue mix is us sitting around trying to figure out how I'm going to pay rent. And we're talking a little bit about how I'm going to figure out how to pay in my entertainment budget, or maybe a car payment. But I feel like, so I know there's a lot wrapped up into that, but I just think that if the initiatives that we're going to give the foundation is consistent with what we've had in the past, the foundation should be paying for it on its own. But I would like to explore this idea of how it could support some of the operational expense side, because if it does, I think if I'm managing the checkbook, I'd like to have the opportunity to pay for that salary to bring in that benefit. So, and then the last thing I'll just say is it's really interesting how, I don't want to say diverse we are as a board on this, but clearly there's a lot of some opinions that I think require some alignment from all of us. So I don't know what we do about that.
Hopefully we can find a consensus today before we leave.
I want to
Yes,
clarify,
Mike could probably tell me if I'm wrong, our bylaws currently do not allow for it to help with operations. It would have to be a complete revamping of bylaws as we stand right now. Oh, we're Dale. They're in here, right?
Which provision?
The contributions that are given to, donated to the foundation, when the foundation expends those, they have to be specifically for the benefit of Star Valley Health. I don't think it necessarily says anything about capital or operations.
Okay.
But one of the things that, from a fundraising standpoint, I do know this. If I'm approached by Ally to contribute toward a baby warmer in the OB department, that's a lot easier for me to contribute to than it is for Ally to approach me and say, hey, can you help us pay our light bill this month?
Right.
So I think that's really important that we provide that opportunity to our donors to know it's this specific item that I'm donating to. Now, maybe Mr. England doesn't mean pay the light bill, but I think that we've got to be really careful about how we sell the, I mean, honestly, there are going to be capital expenditure items that this organization cannot afford to buy this year. 2 HVAC units on top of this room specifically have been put off of the budget for 3 years now. It'd be a lot easier for me to contribute to that as a donor, knowing that they're going to go for those HVAC units. Now, so I feel like we've got to be really careful about how we share this with our community when we're asking them to be joyful givers, right? So,
Mr. Chair.
Anything else, Mike? Jeff?
I just want to agree with you where I can, because I think you're right with this from a fundraising perspective. The baby, what'd you say, warmer incubator is clearly
the winner.
The winner, right? I mean, who doesn't want to get behind that? But I think you could also see a scenario where it's like, well, we could also use some funds for that, like, oncology center that we bring in, that the majority of the customers or patients that are using it are in that Medicare mix that has some of the revenue problems. And now I've used hospital operating expense to build out a new facility that contributes to the problem that I have on my revenue mix, and I've just created a death spiral, and I've used the hospital funds to pay for it. And so I think you have to consider not just what's a good message to generate the donations, but be honest with ourselves about how we intend to use those funds, just so that it doesn't get us into a problem that is perpetuating what we're already experiencing, which is why I say I think it's awesome if we want to have it be for some capital budget items that are additive to what the hospital is doing, but the foundation probably ought to pay for that so that I don't create more of the problem that I've got from a financial perspective to begin with.
The other 180 that I took was when I do donations and somebody calls me up with the phone for something, one of my first questions is, so how much goes to administration? You know, it's usually 10, 20%. I don't know what it is. It's different, and some of them hee-haw around it. Sometimes they never say it. There are organizations that I can fund that I know are not making that. They're not any administration. They're saying, yeah, everything goes to the contribution. That makes me more willing to give when I hear it that way. Just me personally. And but it is, so that was one of the other things that kind of also flipped me as I heard that from the foundation board, and obviously Jeremy is talking about that same subject. So anyway,
if I may, just to maybe add to Board Member England's comments there, I think we're all on the same page here.
I do too.
It all works together.
let's talk about the oncology program as an example. If we specifically target some of the people who have benefited from our oncology program, and we create a targeted fund within the foundation to support the oncology program, and there's a way those funds can be earmarked to be only spent on the oncology program and its specific needs. So I think we're talking the same language here. I really do. We have $900 and some thousand right now in the foundation bank account. That is an endowment fund. So whatever proceeds come from that are specifically meant to be used for capital items for the hospital. That was the agreement we made with the state of Wyoming when they matched that fund. So the proceeds from that need to be spent on capital items at some point in time, and not just sit on them in the bank and let them continue to grow, but we should be spending those dollars on specific things. So I think we're all speaking the same language here about how we would expect these funds to be spent.
Dale, comment?
Because both organizations are tax exempt, you have a lot of flexibility. So the articles provide for the purpose of the foundation to be organized exclusively for charitable, education, or scientific purposes, supporting activities of this hospital. So long as the consideration or donation from the foundation to the hospital supports the hospital's activities, you're within the scope, whether it's capital, whether it's operations, it doesn't really matter what it is. And just as one example that points this out, when we had Mark Taylor as a shared employee, if I'm remembering it right, the hospital paid his full salary, and then the foundation actually just wrote a check to the hospital reimbursing the hospital for that salary. So if Allie raised exactly her salary within the first year, and then the foundation just donated that back to the hospital, and it was just a wash, there's something wrong with that. Obviously you wanted to raise more money, but you could do that. My point is there's a lot of flexibility.
So with that discussion, do you have a final comment?
Just for people that are watching the numbers, just because I think this is helpful, but Dale did bring up the point. It is a fact that there was some shared expense between the hospital and the foundation. So to look at real numbers and to gauge our success of the foundation, depending on who's paying that salary or not, that is technically also an expense. I understand it's coming from a different stream, but we were paying half of Mark's salary. So, and I don't remember the arrangement with John at that time.
So it's the 60. I think we paid him 60 for that year.
Did the foundation pay half his salary and the hospital paid half his salary? Do you remember?
The foundation paid it all.
The foundation 100%?
Hospital paid 100%, and then foundation paid us half of that.
Of John and of Mark. I'm just saying, like, this number's part of the picture, and so like to track.
We're all in it together.
Yeah, right, but.
So, and it is optics. So what I'm looking for is a consensus of this board to give the foundation board direction on those two things. Do we want a full-time director concentrating on charitable donations, such as Allie presented to us? And second, is the hospital willing to pay the salary so that the foundation can say all of the 100% of your donations go to X?
What's the presentation to pay John's salary? Is that coming from the foundation, or is that the hospital 100% too?
Hospital.
That would also be hospital.
I don't think so.
8-to-1, you don't think that's a return? Not even sure.
It's not a factual
Bank makes
return,
that.
that's what I'm saying, this
Sure
is part
it
of
is.
the picture. It's
It
not.
was 500,000 and we paid him 60.
Did the foundation pay 100% of his salary, or did the hospital pay half?
Whether you did or not, it's still the same return. We raised 500,000 and we spent 60 and a half of Mark's, I guess.
So I think
30. So I mean, it's still a large ROI.
So I think, Mr. Chair.
Go ahead.
So one of the things, and maybe correct me if I'm wrong here, but we ran a campaign, right?
We did.
So we hired that
John.
out for $60,000, right?
Yep.
So I think maybe, again, coming back to it, what if we would have ran a campaign on our own?
Yeah.
What if we
Putting it
raised
into alley.
I don't think we would have made anywhere near
But-
500.
Well, but
Look at the previous year.
again, the point being is we don't know that. and I
We
think
don't know
that's-
your blueprint.
Well, yeah, you
previous years.
don't ever know. You can't rerun it, but look at what we did historically. Prior to that year, the highest was 100,000.
I understand.
The
Is that-
lowest
is
was
that kind of where you're
25.
going with
Yeah,
that?
that's kind of where, yeah, exactly, yeah, cool, yeah, thank you.
Like,
I
we're all
disagree.
pretty comfortable in putting,
Yeah.
energy behind here, but we've done the John Gottlieb thing, and then that was, I was here the whole time. I know how the story goes, and it wasn't what it was supposed to be.
Right.
And if she needs some training with him, some one-on-one to like really feel like she's got it, that's one thing, but to continue to keep paying that, like, I could read the playbook, I get the playbook, like, to start hitting employees and asking for their donations, like,
Yeah.
there's maybe some timing on that one, but certainly some one-on-one relationships with big money donors, that seems like a great way to spend time. I don't think that takes, John, sorry. I gotta go
Yeah.
for a few minutes, but if we're voting, I'm happy to vote on something.
So we have a motion? John, comment.
You need John.
John would be an
No, you need John.
Right.
for this to take off the way you want, yes.
For how long?
I feel like that 6 months is a great opportunity to see. The hardest part for this position and complete transparency is going to be getting the foundation in place. Based off of the research and everything that I've seen historically, we have not done a great job of putting those foundational pieces in place. It will move immensely quicker with John's help and guidance. I can read the book. I would fumble through this quite a bit by myself, trying to get the friends of the foundation, the employee, the patient, or the employee, the physician, the foundation board giving to do the Grateful Patient program. I would do well with the annual giving, that stuff that I've got a lot of experience in. But if you want this to take off the way that I envision it could go, John will be an astronomical asset. I would say that 6 months with him, with me working in a full-time capacity, because again, this was initially thought to be part-time while I'm still doing HR. But if you put me in there full-time with John, I would say realistically, I could accomplish 12 months worth of work in that 6 months exclusively focused. So I feel like if we start with what's been originally proposed, that would be a great opportunity for us to see, again, re-identify if there is a need at a continued timeline. Do we want to do it month to month at that point? Do we want to do another 6 months? But that would be a great opportunity for both of us to come here, present our findings to you, let you guys grill us, and then figure out what the best next steps are for the hospital, for the community, for everybody involved. So that, yeah, I would say he's valuable.
My question is, we already had John come in and try to do this once.
We're staying
To put this in place, put all these things in place.
No, we didn't.
He came in
No,
and
he
talked
came
to
in
us and
for Alpine
presented this whole
only.
thing, and we paid him.
What I
We paid
remember,
him
it was
for-
Alpine only. It was an Alpine campaign, for the Alpine Clinic. Now, I'm glad to go back in the minutes and look, and I've probably forgotten.
But
That's what I
But
remember.
it was these same things in place, I thought, though. He presented these 4 pillars of stuff, and I don't know. Anyway.
Could have been.
Mr. Chair.
Yes.
I guess how I look at it, going back, because I wasn't around when he first came in, but it sounds like to me that you had a good head coach, but you did 0 player development. I mean, you had players, but you didn't focus on player development. And so maybe you had a winning season, we got 500,000, yeah, it's a winning season, but you didn't make the playoffs. Damn sure didn't go to the championship. Right? So now we've done player development. We've got a good head coach on board. We're gonna go, okay, let's see if we can make the playoffs this year. I'm not saying the championship, let's see if we can make the playoffs this year. Right? I think you have to have, in my opinion, you have to have both those pieces in play to have a hope for it. Or it seems like we're just gonna go back to the same thing, well, we're just kind of, nothing against your skill set. We're just kind of making a half measure. nothing against you.
None
I
taken.
just don't, I see that we're putting her in a position and not giving her the tools to succeed.
All right, so, do we go for a motion and a vote? Have we talked about it enough?
Can I add just one more thing?
You always can.
Can I get it? Okay, that's good. So, do we have a number of like, if we say, what's it gonna cost us to have John on board for 6 months? Do we have that number?
Yep. 24.
24,000.
Is that right?
I can address that, Mr. Chair.
Please.
Mr. Gettler has offered us a contract for $4,000 a month, which would include daily communication with Ally, as well as 1 full day per week in Star Valley, working with her for 6 months. And then at that point in time, we would address the contract to determine whether or not we would want to move forward or not. That's the contract that has been proposed to us.
And how long was it given? 6 months?
6 months.
So, a couple things, if I may, just, I honestly do feel like that there are more opportunities in this valley to raise money for the foundation than what we've been tapping into. I mean, 100%. I've told Dan that. Dan and I have had many conversations about it. We probably get tired here from you.
I don't.
But, truthfully, I do see that, but I do think we need to see some performance for what we're doing, because like Mindy, I will say, we did get a big spill about how we're gonna raise all this money for Alpine, and it's not to take anything away from where we did, or where we got, because it definitely was probably more than what we would have got without it. But I think we need to make sure and measure the value that we're getting out of it at some point. And so my thought is at some point, if we go this route, we need to have a check-in for sure. And if that's in 6 months, so be it. But we need to have something to be able to show that we're getting some value added. And I know you can't judge the
Great
whole
idea.
process by 6 months, but
You should be able to see some progress forward.
absolutely. And I because like I say, we have heard a lot of it before, but at the same time, I am fully on board with that. We've got to put a little bit of money out to get us to where we need to be. I mean, there's opportunities out there. Just we need to make sure we're reaping the benefits.
We need, and I like Clint's scenario. That was close for the season at least. Anyway,
Mr. Chair, could
can we get a motion? Oh,
Could I offer a positive comment to the board?
please.
I would like this board to know, Ally's current director has given her the opportunity to job shadow with me for the last few weeks, as we have been working on our annual golf classic foundation golf tournament. And with Ally's assistance, I can let the board know that this will be the most successful, on the bottom line, golf tournament Star Valley Health Foundation has ever had. So with Ally's help, I can just see that there are opportunities here for us to really be successful. Thank you.
We're ready for a motion of any kind. Anybody want to raise a motion? Yes.
Are we on foundation strategy or foundation executive director position?
Both. And they may come in different orders, so keep it straight. So first of all, I want a consensus about telling the foundation board what the direction ought to be. Do we want to go full-time director, or are we going to stay as is? That's to me the first. And the second is whether or not the hospital will pay for both. I mean, the mentor and Ally's.
Are you looking for two motions then?
You want to put in one motion? I'm okay with that.
So
if you can keep it clean as
I'll try to make
one
a
motion,
motion
I'd
as
love
clean as I can. I would make a motion that we give the foundation direction that we want a full-time director to engage. What's his name?
John. Yeah.
John. And that the focus is for the charitable donation, the giving, and that the hospital would pay for that salary and for the contract for the first 6 months.
It's a mentoring for Ally, right? Or training, however we're gonna call
For the first 6 months.
it. And then see where, and
And I think we can
evaluate.
see at that point if it's whether the hospital continue to pay for that or the foundation continues to pay for it. I'm personally aligned, and I think we all are too, around what the focus and having the director. I think seems like our concerns are maybe just around who's gonna pay for it, and I think if we.
I agree.
And then I don't include this as part of my motion, but I think I would like to invite the hospital management and the foundation to consider ways to use some of those funds that are there to help offset some of the operating burden that the hospital has, if it can help accomplish some of the goals, just because of the reasons why. But that's not part of my motion.
Did you get the motion, Andrew?
Because that drug on a long.
Did you get the motion, Andrew? Hang
Sure, I
on.
have this
Let
right.
Andrew read the motion that you're going to be voting on.
Jeff England made a motion that we have a full-time director with a focus on charitable giving, paid for by the hospital, along with John Getler, paid for by the hospital for the first 6 months.
Yes.
Is there a second to that
I'll make
motion?
that nicer, but that's.
I second that motion.
Okay, so we have a motion by Jeff, second by Clint. Further discussion about the motion? All those, you have some discussion?
I would,
Please.
well, I would say the hospital pays Ally's portion, pays her, the hospital pays that, and that the foundation should pay for John Getler to be the mentor. That's my,
Okay, so let's see how this motion
Okay,
goes, and
that's
that will
fine.
be a follow-up motion
That's
if this
fine.
one dies, I think.
Okay.
Would that be right?
Mr. Chair, should we actually separate that motion?
I don't think we need to.
As I say, because we talked about the 6 months in there, do we need to say,
We have a motion on the floor that's been seconded, we have to vote on that motion. Or they withdraw it. I think we take the motion
So
and
with
we
this,
vote and decide how the outcome is.
so what's a 6 month time period on?
From today.
Does it include?
June 1st is when the contract.
But does it include the executive director of, plus, we're saying, hey, that.
Yes, both.
We're agreeing that direction just for 6 months?
Yes,
To be reevaluated.
that's
The
to be
executive director
reevaluated in
and
6 months.
John.
Both to be reevaluated in 6 months. Isn't that what you said, Jeff?
Yes.
Any other discussion? All those in favor of the motion signify by saying aye.
Aye.
Yeah, I'll say aye. Yeah, I mean, I made the motion, so.
You don't have to agree to your motion. Many boards function that way.
Yeah.
So you're aye. I counted 3. All those against?
I,
I'm voting in favor of. So that will be 4-2 and 1's absent. Motion passes. Anything else you want to pass on to the foundation board? Trustee board? Okay. Moving on to the next item. Let's do the auxiliary report and then maybe take a short break. I hope you all came ready to have a little bit of a lengthy meeting tonight.
Board members, thank you for consideration for the foundation. Appreciate it very much.
Thank you. Who was at the, Jeff, were you at the auxiliary? The note said you were.
Yes,
Would you like
I
to give a
was.
report?
That's the one, okay.
We were the
Yeah, the tag
the
team.
token mills.
Yeah, I guess I didn't really do some advanced preparation to report, so I'm just gonna have to kind of go through some memory here, but it was the first one I had been to.
Okay.
And so it was just a little humbling to see the kind of support and the enthusiasm from the auxiliary members that were there. I guess I can't recall specifically what some of the activities that they had planned up ahead, and so I wish I could give a little bit better report on that, but they seem to be pretty positive. My general tone was about what they have coming up from there. It was just good. I did field a couple of questions that they had. Just coming from the board, some of the conversations that we've had, I think it just gave them some confidences that the hospital moving in the right direction. And just honestly, it's just an opportunity to express some gratitude for them as well. It was the Cinco de Mayo sort of lunch celebration that they had, so it's just a good opportunity to be there and to encourage them and thank them for the work that they do. That's probably the best report I could tell you.
Well, fit similar to the minutes. Anything you wanted to add, Dan, since you were there? Okay.
Jeff was stellar in his representation of the board.
Okay, let's take a 5-minute break and be back, and we're gonna jump back to Finance Committee. Right.
just going on.
Yeah. No, and that's fair. So each one of them different. So if it's not.
We'll break up your discussion, Abby. We're gonna start.
Thanks for coming.
One of the things I did want to say, and I appreciate board members being able to be here, and if you need to leave, and if you can come back, that's great. I said, noticed Abby, and Mindy said she had to leave for a minute. She's coming back, so we appreciate the time that you can put in, and we appreciate your discussion. So, and hopefully, we'll keep it as concise tonight as we can, but I know we have a lot on the agenda. So, moving on, we're back to new business, item A. The report from the Finance and Construction Committee, and then we'll turn some time, I assume, over to Dan first on budget. And is that how you want to do that, or is Cole going to do budget?
Cole's gonna do. We can do it, we'll do it tag team.
You're up. Okay. Sounds good. Thank you for coming back to me here. So just kind of quick overview. Just kind of go running through the financials. Some of the highlights I pulled out. Days cash on hand was up 4 days from the previous month of the end of March, up to 29 and a half. Additionally, there's a couple things included in the third-party payer settlement line item, I believe. There's $1 million that was basically should be coming here shortly. I don't think we've got it yet, though, right? So for basically the amendment to the cost report in 2025, and we have 397,000 accrued for the amendment of the cost report in 2024. That is a known quantity at this point in time. That is subject to change still, but at this point in time, that's the estimated back. So that is a little bit of positive news, if you will. Should be expecting an extra $1 million here shortly, and then more to come down the road with that. We did add a little bit of cushion for the potential CMS payment or adjustment down the road. As far as the liability goes, about $200,000 for the month. There was the other thing I had on there from the balance sheet was there was a pretty significant reduction in the allowance for doubtful accounts. And correct me if I'm wrong here, Scott, as well, but my understanding was that was really a result of a reduction in self-pay accounts for the most part. It's a combination, but that was kind of
the most part coming from there. The calculation you use, the risk is going down, so you've got it we went from 75% to 55% self-pay dollars that are under 180 days. Everything over 180 days is already 100% reserved. So we're seeing some good move right there.
Yeah.
Can I ask a question? When we were in strategic planning, at that point in time, when we were going to settle up with CMS, weren't we at like a $1 million deficit? You remember this conversation? We were like, how can we get our accruals better? And it's like, you can't because they change their mind mid-year whenever they want. Does anybody remember this conversation?
We had a $700,000 accrual.
Yeah. Did we end up having to pay that, or was just we did pay that? Now we're at $1 million swing that they owe us back.
Well, that's because we're going back. So that's for this year.
Okay.
What we're doing is amending the last fiscal year's cost report.
Okay.
We're getting $1 million back.
Okay. I knew I had some numbers screwy, and I was like,
now you're right on. You're right on.
We still paid,
I get it. You paid it. That was the fact.
Fiscal 2025 settlement, if I may.
Yeah.
Was a total of, let's say, $690,000.
Yeah.
Plus another lump sum we paid in, which was about $390,000. So in total, we paid CMS, or they overpaid us, we paid them back.
Right.
Just shy of $1 million for fiscal 25.
Yeah.
Now, when we amended it, we got all that back basically. So it kind of leveled us out, if you will.
Yeah. And remind me, where does that appear on the income statement? Is it reduction expense or revenue, and is it?
It changes, well, because we can't go back and perhaps prior year, but it goes, reduces the deduction from revenue line. It's the contractual adjustment related to.
In the current year.
It's in the
That,
fee.
that revenue in the current year is where we
When
will
it
see
happens
that.
like that,
Okay.
that's.
I don't know.
And
I
then you
doubt-
already recorded that, and then you got the receivable? Okay.
We still have the cash yet.
Should have been 15.
Thank you.
That's the-
Okay, go ahead.
So, real quick, the other thing I was gonna touch on, we did touch on that in the, I believe in the accounts payable line item, there is the amount that's still out there accrued for Change Healthcare, about 940,000. That is a number that they're saying we owe them right at this point. So, that's more to come there down the road. Just kind of jumping to the income statement or statement of operations. Essentially, we came in just a little bit shy of plan, about $300,000 loss. A couple things there. There was a one-time hit in the, I believe it was accounted for in the, is it the supply section?
Supplies.
Yeah, anyway, so basically a 340B issue that was a one-time hit that we had to take, which accounted for, without that, my understanding was we would have been basically break even, right? And so without the one-time hit, the net income bottom line, we're flowing at a $3.2 million loss for the year, fiscal year. Again, EBITDA, earnings before depreciation, up above 4.4 million positive. Plan was at 6 million. So we are shy of that, about 1.5 million of our plan. And then really, I guess, without other stuff, I really just kind of want to touch on the proposed budget and there's a summary sheet of kind of the changes that goes over.
Talk about the bridge.
Yes, the bridge. Yeah.
It's on page 45 of our board report. I think I'm reading the right number.
Yes. So that net income bridge basically gives us the kind of the idea of where we're sitting to our forecasted loss in fiscal year 2026 is 4.2 million. Essentially, these are the items that they're trying to bridge the gap, and the forecast of 2027 net income of 2.8, almost 2.9 million. The assumption on here is a Medicare mix of 49%. Again, it kind of shows it on the side there. The impact, if we happen to, if Medicare mix actually comes in at 47.5%, it'd be a benefit of the 668,000. If it happens to go the other direction, it comes in at 50.5%. Of course, we have the same amount negative off that net income. And again, like I say, they went through great detail on the profit enhancements. There's a lot of thought that's went into this, and honestly, a lot of time that's been spent on coming up with this budget and how they're going to bridge these gaps. Yeah, with that, I guess Scott, Dan, if you guys want to add anything.
Okay, well, should we start at the end, like the consolidated look?
Maybe you ought to stand up at the stand and make sure. No, we were kind of getting away from things, so speak up.
All right, so in your packet, we have this.
The one that has the color at the top, hospital, EMS,
Right.
care center.
We decided to look at it, and make sure that it's understood that there's a consolidated column over in the far right. But we have it broken down to just the hospital operations, EMS, care center, and then consolidated. And then just showing that the fiscal 26 where we're pacing to come in at is our best estimate, and then fiscal 27 plan. So the bottom line is, like Cole was alluding to on the bridge, we're taking a little over $4 million loss that we're going to likely see, and bridging that to a $3 million income. That's a $7 million swing. So if you look on that go down the far right side, it says the year-over-year change. The big numbers are there is that we'll bring net patient revenue $2.4 million greater than current year. That's coming from a large volume increase of gross charges about 12%, but the net patient revenue is about a 5% increase. So nets to $2.4 million increase, or about 2% year over year at net. We have the process we went to, Cole alluded to this year, for the first time, we went down to the department level, comparing volumes, 25, 26, and forecasting 27. Every department is generating volume. And that was a very good exercise. We appreciate the involvement of all of our departments in that. So that's your top line, $120.5 million. The operating expenses, regardless of the large increase in volume, we did keep the salaries and wages basically just down ever so slightly at 25% decrease year over year. So we as a hospital believe we have capacity to serve that volume on the top line with the current staff that we have. The benefits line is the largest difference on the expense side, and that's the reduction of just shy of $2.5 million in benefits. The largest pieces of that would be the health plan restructure, which is in place, and then the reduction of the match on the 401k or pension match, down from 6% to 4%. That's that $2.469 million. So the net salaries, wages, and benefits is a total reduction in cost of $2.7 million. If you look at that on a consolidated basis, that's 62.2% of the net revenue. So that's moving in a very positive direction. That year to date, today we're at 66.4%. If you look on the income statement, so that's a big movement. So the other operating expenses, other than salaries and wages, benefits, we're reducing those by $1.9 million year over year. And a lot of that is locums and contract or consulting fees that we had one time expenses in 2020. So that's $1.9 million on the other operating expense line. So the total income before depreciation is, that change is $7 million positive, 5.5 this year to 12.6 next year. Depreciation is fairly flat, up slightly, about 2%. So the contribution margin, or the net income for the organization for the year, is $7.1 million greater than this year, as the plan. Any questions at that point? Just looking at the results, consolidated results. Okay. So just run back through the hospital operations includes everything but EMS and the care center. They're separately stated there. I don't know if you'd like to go over there, but we have improvement in the care center slightly. The EMS, I think, it's pretty much, it's going up a little bit in its loss, but based on what we know now, I think that's probably, there's a lot of question marks on that. But we did assume that the EMS would continue as it's currently constituted in this budget. Nothing changing, keeping the same level of staff, patients, with some exceptions to try to do as best as we can on expense reduction. But anyway, I'm open for questions here.
My only question still is well, it's interesting. If you look at where we're at this year on plan, we're $1 million less I'm quoting this right, $1 million less in total revenue. And our expenses, as you said earlier in the meeting, Dan, are not on budget, what we planned. And so not obviously, but the loss that we're looking at, some of that is,
At the net revenue line.
I'm looking at total revenue. 98 versus 96. I mean, it's a couple million different. It's down, right? Is that, yeah, that's net. Total net revenue.
Yeah.
And expenses are within 100,000, I think, a couple of hundred. And so, you know, we kind of met our plan, except that 2,000 we were down, or 2 million, I guess. And that's probably where the biggest is from net revenue. So, as I looked at this, and I kind of expressed this at the finance committee, we're hoping, or we're planning, that our net revenue comes back to 2025, and that we can get back to that level. And I mean, every year before this, we've looked historically at the very past year to kind of figure out where we're going to be in our plan. But you guys, I mean, it's evidence that you planned pretty well. So I'm not opposed to this plan, but I'm just wondering that we're really going to be able to get net patient revenue up by 2.4. I mean, that's the key to me, because that breaks up. If we don't, if we're at this year's for revenue, we're basically around break even again, right? I mean, if you don't make the net patient revenue. So, and I realize the crystal balls look pretty darkly. We're hoping Medicare, the mix, excuse me, not Medicare mix, the
Commercial
mix.
mix, you mean?
No, just the mix.
Commercial, just the mix, the blend, Chevron versus
The payer mix, you're right.
payer mix. Thank you. That's actually maybe the better way to look at that, a payer mix. It just concerns me that we're that optimistic that we can get clear back to our 2025 numbers on 2026. I'm not sure why we had, my 2026 was down, except payer mix seems to explain some of it.
There's volume as well.
Volume was down.
Right.
Instead of the baked-in growth that you anticipated, numbers coming off of like 10% growth in the department, or what?
Depends department.
Okay.
Each department. But
I remember kind of the numbers.
month by month, they went by where they thought they would deliver the volume, visits, procedures, tests, labs, and procedures and radiology, etc. So we went back a couple of times with the team, saying, look, we're not asking you to give us a number we want, but what do you think you can really do? Don't be a hero.
Yeah.
You're not trying to, we're just trying to be realistic. There's a lot of optimism about getting back to those. We have new providers filling in the gaps of something like Dr. Affleck that, when he left, that left a big hole.
Sure.
Procedure, so that's coming back. And we have other.
Certainly some probability that we can get back there because we have hopefully additional procedures from new docs. Yeah, what, is there a forecasted probability for management or what we're, when we get there, and we're 90%
One way I
sure?
could say the forecasted probability is 49%. We're estimating that very high for a reason. You know, because that's the worst thing that can happen.
You're trying to be conservative.
Very conservative on the payer mix. If that goes over 50%, then, you know, that would be a real, for the entire year, right? That would be.
Average, 49. That would be
That's
okay.
just average is 49 for the entire year, so it's budgeted on the payer mix.
But we could tolerate a 48 and a 51 swing.
But yeah, if it was like, I had a little sensitivity house there, you know. 50 basis points is $40 million. That's not very much. Very slightly, you gain money or it really hurt. You believe that there's.
Even if we grow to 50, and let me make sure I'm reading this right. It's a 668,000 dip reduction in net the patient revenue, correct? So if everything else came to fruition and that changed, we're still positive by year end. Am I reading the numbers right? The tea leaves?
Yeah, so I think the confidence, not the optimism, but the confidence in the budget needs to come from the process of how we develop the volume, very detailed by department, by position, by procedure, and everybody's involvement with that on a monthly basis. So that's number one. Number two is when you're trying to manage a volume budget, you then have to do a probability analysis of what really is realistic of that volume materializing. And we mentioned the providers that have been new that are still growing their practices, and the incremental volume associated with that. We're not talking big numbers. We're talking, maybe 1 or 2 cases a month, right? So we're even conservative with our volume estimate. So it's always volume and payer mix, right? And so we're conservative. We're trying to be conservative with payer mix. We could be wrong. It could be 50, 51, 52, right? But without question, the demand for healthcare services are always going to be there. We just don't know what the mix is going to be from the payer side. And so if you look at our net revenue growth over the last 4 years, this is the lowest that we've pegged, 2% of net revenue growth. So where we're putting the pressure, where management is putting the pressure on itself, is the only lever is the focus on expense reduction and finding efficiencies within the organization. We have no other lever, but we also don't want to forget about growth. Okay, if we don't, there has to be opportunities for growth in various service lines, and so as we're having monthly operating reviews and conversations about the numbers compared to budget, what are we doing to grow this business? What's keeping us from patients coming in the door? And so it's an ongoing challenge, but it has to happen so that number, which is key to hitting our targeted net income number, it actually comes to fruition. So we've proven that we can manage the plan, the expenses. I think that's demonstrated just in this year, right? So we're under the plan of expenses. Where we miscalculated was the payer mix, which we believe is the reason. We don't believe it. We know that is the reason for the net revenue, the net revenue miss. And what you're seeing here in this plan is a significant reduction of expenses year over year. So that is, and most of that has already been baked in. We've already actually enacted those initiatives. So I think that considering our circumstances, we still have to figure out how to grow. We have to be mindful of the payer mix, but really it's about managing the expenses every single month to making sure that we're disciplined so that if it does go to the 50 or 51 range, we have no other option but expense management.
But Dan, when you're talking about growth, you're talking about more organic growth, right? Internal. So
what do you mean by organic?
So we put all these things in place.
Okay.
We need to see them come to fruition. Yeah. So the investments, yes, the ROI. We need to see that ROI. So we may have a good start with this, but this partner of practice or whatever it is, or provider, they may only be doing 50% of where we want to get them. We just want to see that out.
Kind of like spine.
Yeah. So it's not per se going out and putting a new remote clinic or.
Okay, that's
it's
organic.
just purely organic.
That's not organic.
So the
internal.
Make
an investment.
What we already have established.
That's exactly right.
When I go buy organic, I don't like to buy organic. It tastes better and it's a lot more expensive. So I need a definition of organic.
Yeah, so he gave a very good definition. Thank you for the clarification, Cole.
in-house.
It's investments that we have already made, so we're not spending more money to develop more revenue.
There's capacity.
So we spent,
Okay.
so we've already spent money to develop this revenue. We
That
just
makes
need to see
sense.
it
Okay.
Can I ask a question, which you can totally.
Yes, you
None
can
of
ask
this.
any question you want.
When you do a plan like this, just because I'm being totally honest, that's like, I get the overall picture of what you're going for, but when we're talking like days cash on hand that we're trying to improve, is that baked into anything here? Like if you actually achieve your goal, does that net revenue convert to days cash on hand because you're not spending it? What does it mean?
That's part two.
Oh, okay, you can just dot. I'll just hold my question.
Because you can't have days cash on hand from today unless you have what?
Revenue.
Collections?
Well, yeah.
Revenue first.
Profit.
Profit. Right. Or you borrow.
Growth.
Or you borrow, or you have some deep pocket, somebody gives 10 million to the foundation and they give it to us. We don't have investors. We don't have a source of,
Capital.
So anyway, I can show you this in a minute, but how we reconcile this to forecasted days cash on hand.
When you get there, I'm comfortable.
I just want to make sure that first and foremost, the source of that days cash on hand will come from this $7 million turn.
Sure.
You divide that by 3, and that's about the number of days, 300,000 for the whole day.
So one of the other comments is, as I look at this, and I'm pretty simple-minded on this stuff, is when you do the overhead allocation, it's obviously where the loss comes from. And so it would seem to me, and I have no knowledge of this, I'm not here watching every day, but maybe we have too much overhead somehow, and that's this cost efficiency you're talking about. And that's what I'm excited about hearing, is that we're really focusing on cost,
And one of the things
changing that.
Yeah, one of the things we did also this year is we took things that were generally in an overhead bucket that we allocated, and we specifically charged them to the departments they're going to, more surgically, right? The biggest one was our charges from OJ. They're going to the departments that actually use the licenses related to that department.
So you've allocated a proportion that.
Yeah, that means there's less going
Better,
into Chris's budget
formula.
that's allocated across the whole entity based on FTEs. It's that those general expenses like IT it's pretty general. You could get down to like who has each department, the number of computers they have there, the users they have, but we do that.
Blanket.
Yeah, use real general, like general licenses for Microsoft and.
Did you send that list to the board that you sent me by email? Your allocation? Some of them may be interested in that.
Okay, what I said tomorrow is the asked for it, and I could give it to you, is this, the allocation methodology for each department that is considered a general and administrative department of, repairs and maintenance.
Yeah.
IT, finance and accounting, administration, environmental services. Run this.
Was that an annual?
Employee
number?
benefits.
Was it a 12-month look? What was it? I don't care to see it.
Spring years, Pat.
Yeah, so we have just, each of these departments down the side are the kind of a general and administrative department, and then how it's allocated is.
It seems like you're taking more of a scientific method of allocation than.
Well, if you want to make it right, number one,
I agree.
It
more
is.
accurate,
The level of detail, this is unlike any budget in the past.
more accurate, we can provide one of these directly to the department who's generating revenue. It'll affect our reimbursement dollar for dollar. So this is an improvement. Tanya says, and this will be the way that we do it on a financial statement basis. We'll do it even a little bit differently on a cost report basis, because we said for our advantage. But this is the way we're trying to fairly allocate those charges. For instance, revenue cycle. What do? They process what? Claims. So the departments generating claims have to pay for those claims to be processed. Depending on the number of claims and the gross charges by department, they're different. So the department with the largest allocation of the rev cycle is OR, right? Versus
The who?
The OR.
They have the largest volume and that kind of thing. So
So
This is just how we've tried to break it down and fairly allocate.
Yeah.
just high level then, like how many allocation drivers are you using now and did that?
We never did this at a real, gap level, at a consolidated level like this, or done that. It just showed consolidated total, so. This,
So this is all new.
it's all new, so each
So
department
you
will
use
now,
one allocation driver
each
for.
month be able to see how much
So-
am I contributing to the total overhead.
Sure, so roughly how many different drivers are you using? You mentioned FTEs.
You got FTE, square footage, poundage of laundry,
Charges and
accumulated charges, gross charges,
Okay,
accumulated costs for non-revenue generating departments. There's one on here that's very specific though, and that's the airplane. So the costs related to airplane are only going to those departments using here. That's the whole heaviness of having to cover that.
Will
So
this convert into a pie chart at some point?
you can see it along here,
Yeah, we could.
the overhead allocation here.
So what page are you looking at? Is that a different?
Well, I'm just looking at what you got here, right?
Oh, same,
Page 44 in the board packet.
you're looking at that same one, okay.
So the hospital itself gets, we can break that down by department or by general groupings of departments, if you'd like. See the pie chart on that. That's come late. I could do that as a follow-on email. You'd like to see that?
No, I mean, if the board wants to see more information, I ask a lot of questions from behind the scenes and they send me things and I guess I'm kind of expecting they may send it to the board, but if you want to see some of those
I will tell you.
more specific items, you're welcome to.
Overhead department, knowing that this would be somebody's gonna say, you have too much overhead. You know that question's coming.
Why don't we do this, Marlo, is, as the board chair, if we send you any information, can you distribute that?
Now you're starting to ask a lot. You're gonna have to double my salary as well.
Well,
That's done, deal, shake it off.
one of the things we do.
0 times 2?
One of the things you do on the overhead is just that there's a lot of benchmarking data that says if you're this size of you're a large hospital, it's 110 or million plus size hospital, and what, if you have a maintenance department, what's the good measure of benchmark, benches can be wide, but average number of FTEs in this department to cover how many square feet of your facility, right?
Right.
That is, so, we looked at each of the departments. Sometimes we may be, a little high or a little low, but there might be a reason for that. For ours, we don't have just one campus. We have many, so we have maybe 1.5 people, long in maintenance. I just think in my mind. The rev cycle, I think we're pretty good on the one side of things. We have some rooms. I think we can further reduce the head count but overall, we look at the head count and then what we're spending per dollar on the net revenue per net revenue. I think we have room to improve still, but we skinnied it down quite a bit this year. One area we do very well is our supply advantages. We're so frugal with our supplies. Generally, supplies run around 14 to 15% of net. We're 10 to 12% year over year. We have really good advantage that no one's team do really well.
So what I would suggest, Dan, in answer to your question is, if administration sends me something, you ought to copy Andrew. I don't work to start over help email all that often.
Okay.
And it ought to go out through that email.
Yeah.
Don't you think?
Yeah.
And so if you want to keep it and start on a health email, I would suggest we have somebody besides Marlo handling it.
Our legal counsel's gonna slap your hand.
Yeah, that's right.
And I'm ready for that. Okay, I'm just waiting. But
So departments have not previously gotten a good
I
idea of
turn all
what
my
the
emails
department.
over.
Yeah, in the past. And like, these numbers reflect the last 12 months, would you say? What do they reflect?
This is an annual.
It's an annual.
This is the annual look forward. The 26 is the annual kind of look back. So you look
And
at.
1 year from now.
You look at, for example, the hospital, the first two columns. This year, the allocated overhead to the hospital was 24 million. This year, it's 22.5. But you can see the allocation to EMS, 1.2. This year, looking forward, 1.1. Each of the allocations are going down. But each department will have their own allocation. But we're going to focus on contribution margin first, which is say, what are you contributing to cover? Maybe you won't cover all the overhead allocated to your department, but at least it'll be a positive contribution. Try to make that contribution.
And then at least you can compare that year to year. And it really is so vague, and like, they don't know what to improve because they don't even know what their baseline is. We have a baseline now.
Yeah.
It's very good.
So, I think what we're trying to achieve on budget tonight is, are we ready to approve this budget as a board? We definitely want to send it to the state. We need to send it to the state this week as a preliminary budget.
Like every year, by June 1st, it's called a proposed budget. And then if there's any changes to that, we have until July 31st, so 60 days to make any changes that we want. Last year, we didn't make any changes. Year before, we didn't make, if we do make a change that would be material, one way or another, then we present that in that final budget by the 31st.
So I guess what I'm wondering
I need
is,
to also put a public notice in the paper.
Yes, that's
yes,
okay.
is that at our June meeting, you ought to be able to update within a month, year end, and we ought to, or even closer than a month. We ought to have pretty good numbers, so you can say, yeah, we still think this is headed in the right direction, and we like our budget, or we need to tweak it.
Yeah, what we want to do is get the board's eyes on this. Because of the number of hours that we've spent on this, we don't think this is going to change that much. There could be some minor changes of what we're presenting tonight that we will update the board in June. But for right now, this is the overall, what we're asking the board is say, okay, we looked at it, we're going to send it into the state with the proposed budget, put the notice in for June, and then approve the budget in June.
So we don't need a motion.
No.
By the way, from my standpoint, and hopefully the board, we do appreciate both all the accounting, I'm sure you guys have been working, and the administration, for all that you've done on this, because this is really probably more detailed than we've ever looked at that I'm aware of.
It'll get even better next year, the process.
Great. Any other questions from board members about the proposed budget for 27 fiscal year?
Thank you for your work on it.
We still answer her question about cash.
I think I read a little bit, but.
That's the big $64,000 question, right?
Yeah.
How many days?
Which days
That's what's
should end in next year, right? Yes, it is.
Well, you told me the equation, so I felt good about it.
Okay, so.
I'm trying to find
She's
it.
gonna find this, sorry. But, in the cash flow statement, I think it's in the.
Oh.
I think it's in that,
You see it both done, file?
now, might have to pause that for a minute, but the answer is probably around 48 to 50 days. That includes a $2.5 million CapEx.
Oh, she didn't think about that. That would be an easy bite cake. Bite cake if that happens.
Double our days.
Yeah.
Okay.
Plus, if you're really as conservative as you think you are, it could be better than that. But at some point, when you guys catch on hands where you want it to be, then it means you really cap that.
Yeah, so let me get that for you, but I'll send it out to you. Sorry.
Yeah,
So we will submit this, the form you submit it to the state is fairly high level. It's not- there are details, but I may, the only thing I think could change in 60 days if the EMS equation comes into focus, one way or another. It's not gonna get any worse, but this is how we've been running. You know, this is the high quality EMS. Here's what it costs. But if that changes, we may adjust that piece of it.
Lord?
I just, one comment I would make is I think that it's important that we recognize that a $7 million swing from year to year is a big ask in and of itself. So, from my standpoint. So it's one of those things that as we look forward and look at some of the other decisions that are active, again, it's a big ask to get that going.
What, like, can you clarify what those things are in your mind?
Well, there's just a number of decisions that we'll have to come up with as far as like EMS and things like that.
Sure.
Again, if the plan goes as planned, at 49%, that's where we'll end up. But again, that's the estimate is budget and plan. So.
But they have proven if the payer mix wasn't a concern, they're pretty good at that. Following the plan within reason, right?
Yeah.
Is that the track record? Or am I like blowing smoke up my butt?
Well, if you look at just the top portion of the fiscal year to date numbers.
It's a quotable quote.
I know it's recorded, but
I was
it's.
trying to ignore that. So, but if you look at the top portion of those fiscal year to date numbers, there, despite, and Marla pointed out, yeah, we're within $2 million of net. But if you actually look at the numbers above that, there's a lot of up and down movement in there. You know, our gross revenue is actually like $7-8 million above. But then our contractual, you know, the subtraction there was significant more than what we had budgeted. And, you know, again, and then our back debt expense was significantly more, I think it was $5 million more. So there's a lot of movement in those items above that net revenue number that impacted that. And I think that's what we're talking about with the mix and some of that stuff, so.
I could show that if you want.
But that answered.
You got it?
There is the cash flow. Starting from net income, add back depreciation, add the change in AR, which I give the net decrease in overall AR as source of cash. Then the $750,000 would be the anticipated receivable from CMS on the 24 cash or cost report. The change in accruals there, that $1 million is a planning for paying CMS off, or CMS, CHC, Change Healthcare. They say we're still gonna fight it as long as we can with the, on the legal means of the appeal, but if we had to pay it, it's baked in there. Minor changes in accruals and current assets, then that leaves you with $13.5 million from operations.
What if we have to pay CNS?
What?
That's
$1 million.
CHS.
That's CEHC.
That's
It's
changed up.
healthcare, but we had to pay CMS, what, 2.something million?
Okay.
That's baked, that's already in
It's
there?
already baked in the net.
Okay.
Income number.
Okay.
The debt service this year is 3.9, the CapEx, 2.5 million. We don't know what we're gonna get in the rural health transformation, assume zero. That could be.
I'll be talking about that.
We have some cash that's still funding our imaging center. So the change in cash would be 6.4. We'll actually end the year probably closer to 8.5 million. So we'll have 14.5 million, which is about. It all starts at.
Other questions about budget fiscal year 27? Anybody going once, twice? All right. Moving on. I think we're down to CEO report.
All right, Mr. Chair, I don't want to, for sake of time, and you have my written report, but I do want to highlight that big bogey with the Rural Health Transformation Fund. So the big news when we were at the training, the board training, was that Wyoming's application for $205 million in the first year was approved by CMS. So there's no longer this doubt that, well, Wyoming may not get any money. So, but there's some conditions. Want to point out that the two significant components, a state-operated emergency health insurance plan and the long-term perpetuity investment fund, they were axed out of the original application that was submitted. So no more perpetuity fund and no more insurance program for emergency health. All that it remains is basic care, workforce, and sustainability. That's what they agreed on or negotiated with CMS. It creates financial incentives for critical access hospitals to focus on core services, emergency departments, ambulance services, and obstetric care. We do all three. So where they're going to put the dollars, we are right in the sweet spot with what they want to fund. Technology grants will help providers deliver care closer to home, improving chronic disease management and reducing the burden on patients who must travel long distance for routine services. Again, because of our ACO, because of our investment into chronic conditions, we're right in the sweet spot as well for that. And then Wyoming must obligate year one funds by the end of October 2026. So here in 5 months. Aggressive timeline, contracts must be drafted, staff hired, proposals requested, and funds committed. Future funding will depend on how well Wyoming executes in this first year.
Every hospital needs to bring their success.
What's that?
Or will they look hospital by hospital?
I don't know. I don't know how the application process is going to. So tomorrow is a very important call. We're going to get an update from the Department of Health with the Wyoming Hospital Association, so that we'll have more information at least tomorrow. Mike and I had a discussion about what he's really going to be focused on and busy, and that is the whole application process to get access to any dollar that we're eligible for. So that's really going to be our. Again, we don't know how much, we don't know what the applications are going to require, we don't know what's being allocated by area, but based off of the general information that they have provided in the renegotiated application, I think we're going to be eligible for some funds. And more to come on that. Any questions about that?
You know how many critical access hospitals in Wyoming?
Yeah, but not a lot of them are still doing obstetrics. And not a lot of them are funding ambulance services, and there's some, but
You like give me the number if you can, if you have it. 19. Have 19? 19 enough. I like the division of that.
Okay, so
we could solve it. The EMS problem.
That update is very germane to the discussion that we're going to have in executive session over EMS. And also, the whole conversation about days cash on hand. What everybody, I think, is concerned about is once you start introducing grants into a critical access hospital, it can camouflage your operations.
Totally. It's okay that we hit the bottom. Yep. It's really caused some good things.
So what we'll do is we will obviously keep the board up to date on funding that's coming in. But as we hold ourselves accountable to this budget, we'll carve out any monies so that you can see the true picture of how is the hospital doing if it didn't have this funding.
Should those grants go to the foundation?
No.
Yeah, healthcare.
What's that?
It's directly to fund operations.
Yeah, and I was going to say, like, more people, like, if they give you funds and you don't specifically spend it, they're like, we gave you too much.
Yeah.
Suck it back. That's that in good ways.
So now, keep in mind is on principle, Do I really believe that this is transforming rural healthcare? Absolutely not. And if
It's like winning the lottery, you broke.
right? So I don't see anything here that is going to, so really what we've got is maybe 5 years. So the important long-term perspective that I'm seeing this is we have 5 years of some help, but we've got to have a plan to be sustainable from a cash standpoint for those 5 years and beyond.
Okay. Questions for the CEO?
So, or you guys as Star Valley Health, you're gonna have to submit something to the state saying this is how
we are worthy of those funds.
But you have to have details.
Yes.
We're hiring this guy at this salary.
We have to figure out what the justification is, and then we have to then articulate that to be eligible for those funds.
That's easy for us because we've already been doing those things. And so we just say, look at the loss that we already show for providing the service at a detriment to our hospital.
So the caveat is they may say, well, we don't want to fund existing programs. We want to see something new. And then we're going to have to figure out a way how to articulate that to say, yeah, but.
Good luck. Because really, so what, you're gonna hire a guy saying, hey, we're gonna have a salary for you for 5 years, guaranteed. After that, we'll see how you do.
That's Mike.
but no, really, that's what hospitals are gonna be asking.
That's right.
That's gonna be the ask.
That's exactly right.
Is guaranteed we can pay you for 5 years. After that, hopefully you've got a good business built by then, you're self-sustaining, I guess, right?
Yeah.
So I think you hit it on the head. I think we could go back to 2021.
COVID.
Yeah, COVID funding. And again, I think we're looking at some efficiencies that we're working on now that, again, we had that COVID funding and some of the funding that we got that hit some operational issues. Right? So I think it's important that we do separate our internal if we didn't have those places.
The other important piece to this is it is going to also camouflage the weight that people need to feel about funding EMS. Oh, you're getting these funds for EMS. Yeah, but
in 5 years it's gone.
And in 5 years it's gone. So what is the sustainability plan? If you're going to take these funds, how do you utilize them to move towards long-term sustainability? That's rural. In my mind, we're going to have to be the ones that actually figure out rural healthcare transformation. The state's policies and the state's application is not going to do that.
Yeah, and the employee retention credit, didn't that drop in like 2025?
No, I'm talking like the PPP money and some of that stuff. If you look at the hospital organization prior to 2020, days cash on hand would have been around 70. We bumped up to over 100.
Good times.
Oh, we doubled our.
I don't know if anybody calls
money.
It was long
Doubled our
enough
money
ago.
back in those days.
I like it.
So we had 20 million in the bank.
I didn't read it.
Yeah, days cash on hand.
Mr. Chair, Clinton.
So here comes your generative discussion then, right? I mean, what's off the, if you guys are at liberty to say right now, off the top of your head, what's the top 3 things that you're gonna present to the state to show, hey, we deserve some money? What's?
EMS, obstetrics, emergency services.
Okay, but those things already exist, so if they're wanting something new, then we're dead in the water.
Well, no, I think that there is an element of sustainability that they're looking for.
Okay.
So until we have those details of
right.
what the spin is, I hate to use that word, but it's almost
This is like hire your accountants or
Positions.
positioning. Thank you. You know what? There's a reason why he's on the board. Politician. The positioning that we're going to have to take in order to be eligible for those funds.
And I'm sure on this phone call, you're gonna find out the accountability end of it. I mean, I would assume at the end of every fiscal year, they're gonna wanna see.
Some strings attached.
They're gonna wanna see, hey,
Yeah.
how is this spent?
Yep. Okay, so that is a very important update for the board to know about.
So, secrets, EMS.
Emergency services. So,
Mr. Chair, there is another component that's increased telehealth opportunities.
oh yes, that's a fourth.
To bring more telehealth opportunities for patients to stay home to see specialists, so that's another component.
Mike, you only asked for the top three.
Yeah, but we don't even do that at all, right?
We do a few, but not many.
Telehealth with somebody at home? We do a few?
We do telehealth services.
At
In
home?
fact, we just talked today in our compliance committee about having a policy about
And
telehealth.
I know we're spending a lot on telehealth in the sense of ER and hospitals, nocturne, all
Yep,
these
yep,
other things.
Exactly, yeah.
But I'm saying, for me as a patient, I can call in on telehealth and get a,
This would be a component of that, yes.
but it is happening now? Okay. To a very minor extent?
To a large degree. It takes the public a while to catch on to that.
There's a lot that we credential for telehealth.
Well, yeah, and I agree with that, but I'm thinking home. If I call in to my doctor, Jeremy, do you have an answer for me?
Yeah, go with the number.
Yes, if you would. We didn't make Mike do that. We'll make him do it next time.
I'm younger, yes.
Yeah, that's true.
We do a lot of telehealth, especially in the hospital-based services, right? So you're not gonna call from home for a lot of the telehealth you already do.
Right.
The ones you're gonna call in from home, or more likely you'll come in here, you do teleneurology, telerheumatology. For those things, you would schedule appointments, you would actually come into our clinic, and your telehealth provider would be on the screen that way. So in terms of what you're actually asking about, specifically, no, we don't do a lot of that. One of the things, it's not baked into our forecast for next year, but one of the things that Corey and I are working on right now is we have urgent care, we staff urgent care mostly for coverage as opposed to volume, right? We're going from 7 to 7, well, you have to have one provider there the whole time. So we're not so busy that we need to have 2 or 3. But what we've found is that Alpine and Afton, those guys, gals, could be doing more than just seeing the patients there. So one thing we're working on right now is exactly what you're looking for, which would be tele-urgent care. So that then instead of even coming into urgent care, you can go on, you have to do it from my chart, but you go onto my chart, and then, and this is what we're working on, this is not like the tomorrow thing, but where you go into my chart and you say, hey, I think I have strep throat, or I think I have whatever, you go in there, you put in you want to have a visit, and then one of our urgent care providers who's already there, this is kind of what you guys are talking about, organic growth, which is we're not adding any expenses. One of them can pick you up and then, get onto a telehealth visit with you on your phone, and then they can ask your symptoms and go from there. So that's more, I think, what you're looking for is that, you need it now, we can get it for you now type of thing. So we're working on that right now.
Yeah, no, that was my question, but I also see, I would not expect a doctor to make a great diagnosis without seeing me.
Right.
On some things, yes, right? Some things I think over the phone, you can explain some symptoms and they'll say, yeah, that's pretty clear.
But the patient.
But most doctors want to see them with a video at least, I think.
They'll be able to video. Yeah, the patients made the assessment, this is not gonna kill me, and I'd rather die than drive to the doctor. I don't go there already, and I know what I already have, like, you just have to have them confirm it. Like, that people do that all the time.
You're not wrong, though. They'll have physicians who, there's some things they will and won't do. And I think a lot of things over the phone are gonna be, UTI, urinary tract infections, or ear infections, or respiratory things. And you're right, some people are gonna say, hey, I can't look inside your ear on the phone, so I'm not gonna prescribe antibiotic, whereas some will. So, but this model is one that is done, the telehealth model for urgent care is done all over the country, and I think we'll have to find that balance point where it is.
Yeah. Did you have something, Trevor?
I was just gonna say that right now.
Thanks, Jeremy.
My wife uses tele-oncology with Dr. Johnson, and the technology that we have allows him to see her very clearly through the screen, and then there's a nurse there as well that he can ask the nurse.
But she comes into the hospital.
Into the hospital.
Okay, but, that's good. Yeah.
Very cool.
You've answered my question. Okay,
The communication, like it's not a lag when we have the setup in the infusion center, right? It's like a room at the infusion center.
Yeah, it's a big
Very
screen and
nice.
it's very, very clear and we can see him good.
And they know this doctor because they do come here sometimes.
Yes.
That's also nice. Very good. I would say.
okay. Moving on, quickly read your FYIs. Anybody have any questions? We got golf in June and half marathon in July.
Who's doing the half
Looking for a motion to go into executive session.
Could I address those two topics?
Please.
Thank you. Just to give the board a little bit of an update, I mentioned to you that we feel like our golf classic is going to be very successful, and thank you very much to those of you who have contributed to that effort. Also, the half marathon planning is going along very well. The wannabe running 501c3 board of directors, which is the organization we inherited from the Coons family, have chosen to support a college fund for Cassie Klinger's 3 children. That's where the proceeds left over after the expenses, those will go to a college fund for Cassie's kids. And we're advertising that so the community knows that that's what we're doing. I'd like to invite everybody to, if you have an opportunity, to come and have breakfast with us or lunch at the golf tournament on the 12th. And we'd love to have your support too on July 12th?
11th.
Or 11th for the half marathon.
If this is right, it says.
If you're of a mind to get up at 7 a.m. and meet us up at the starting line, we'd love it if you come up and support it. Thank you.
Great, thanks, Mike. Yeah, any motion to go into executive session?
So moved. Second.
You got the language, Andrea, I heard.
For the
I got
purpose
all
where
the
I heard it.
details.
Moved and seconded, to go into executive session for various items.